Hello, everyone. Thank you for being so early and joining us today. It is a really nice and cooling day outside, so thank you for joining us for our forum, even when you can be spending time sleeping in your bed or just doing your own things, especially on a Saturday morning. So, for now, do take note that we'll be starting in about 5 minutes, so you can take this time to grab some snacks or drinks, or maybe even grab some breakfast, and we'll see you shortly. So, we're also pleased to mention that we actually have over 700 signups for this forum today. So if you know any friends or peers that have signed up for this forum but have yet to join the live stream, do send them a quick text to let them know that we will be starting soon, okay? So that's all for now. So do sit tight and we'll start shortly at 9:35 a.m. See you soon. Bye-bye. Good morning, everyone. So as mentioned earlier, we'll be starting at 9:35 a.m. sharp. So if your friends have yet to join the live stream, do let them know that we have started, okay? Because we're starting right now. Okay, with that, welcome to IME. Not hello. Okay. Okay, good morning, everyone. Sorry about that. There's a little technical issue, but I think I should be okay now. So, good morning, and as mentioned earlier, we'll be starting at 9:35 a.m. sharp. So, if your friends have yet to join the live stream, do let them know. If Do let them know that we will be starting right now. So just send them a quick text and we'll be starting, okay? So with that, welcome to I Am Me, Not My OCD online public forum. I am Nadia Nur Azlan, a third year student in the Diploma of Psychology Studies, and I'll be your MC for today's event. So first off, thank you all for joining us today and for being here on time. So we know that it is a Saturday morning and it's pretty early today. So thank you for joining us for our forum this morning. So we've prepared quite a program for you, including multiple sharing sessions by many distinguished speakers. So through today's online forum, we hope that you'll be able to gain more insight into obsessive compulsive disorder, also known as OCD, and better understand how it may affect the lives of individuals living with this condition. So to kick off this forum proper, I would like to invite our guest of honor, Chairman of the Medical Board from the Institute of Mental Health, IMH, Associate Professor Swapna Verma, to deliver her welcome address. Associate Professor Verma, please.
Yes, technical glitch, I'm muted. Hello, everyone. Good morning, and thank you for joining us for this public forum. I'm Me, Not My OCD, a public forum organized by Temasek Polytechnic and the OCD Network. I'm really pleased to invite all of you all today here. So you all must be asking why we're talking about OCD, especially in today's pandemic. Isn't it good to be obsessive about dirt and cleanliness or to wash hands compulsively? So why are we talking? Is this bad? Actually, this is, we all have obsessive traits, and a lot of that is good. It is useful. But obsessive compulsive disorder, it's a disorder, and it becomes a disorder when you get incapacitated by the illness to such an extent that you can't function. So in this picture that you see, which is actually drawn by somebody who suffers from OCD, their life is overtaken by the obsessions of dirt, cleanliness, washing hands. These are rituals. Somebody who spends like hours in the shower or is unable to leave home because they're worried about dirt or cleanliness, or somebody who's checking so often that they're exhausted by it. So that's when it becomes a disorder and needs help. And you may be not aware, but OCD is not that uncommon. The lifetime prevalence in Singapore is 3.6. That means 1 in every 28 people were affected by OCD at some point in their lifetime. Next slide. And the other thing which is concerning, or something that you need to be aware of, is really that OCD starts at a very young age. The late teens, early 20s is the age group that the illness starts, or people are more vulnerable in their younger age. So unfortunately, you guys are at that vulnerable age. And fortunately for somebody like me, I have passed that vulnerable. So your age is an advantage, but this is something that you need to be aware of. All mental illnesses are called chronic illnesses of the young. They kind of, emerge in the young age group. Next slide. And then the other thing that we see is the long treatment delay in seeking help. So these were two big studies. SMHS stands for the Singapore Mental Health Studies, and which IMH undertook. These were population-based studies to look at the prevalence of mental illness. And we also looked at treatment delays. So there were two studies, one done in 2010 and the other one was done in 2016. And here I'm showing you the treatment delay in years. And if you look, MDD is major depressive disorder. So, and then you have bipolar, you have anxiety disorder, OCD, alcohol use. And for almost all the disorders, the treatment delays got better. But for OCD, first of all, the treatment delays were huge, 9 years in SMHS 10, and it got worse, and it went to 11 years in the second study. So people waited for almost 10 to 11 years before they sought help for their condition. Why the delay? Sorry, can you go back to the previous slide, please, Jackie? Why the delay? It could be lack of awareness or misinformation. Like people may think this is not a problem. This I'm just obsessive about things. So there could be misinformation, lack of information, or maybe even stigma. And stigma is very real. It's still there. As psychiatrists, working in psychiatry, we feel stigmatized sometimes as well. And I know it's not easy coming to IMH to seek help. So then what do we do? So over here, I wanted to let you know about this resource that we have. Jackie, next slide, please, which is called Chat. Now, Chat is assessment. It's a hub which is outside of IMH at Scape in Orchard Road next to Cathay Cine Leisure. And on the 5th floor, we have an assessment center, which is really like a cafe style, very cool. And the good thing is that you can make an appointment to go there for a free mental health check. It's free. The other thing is that you are not registered within IMH or any other hospital. And it's very confidential. We don't insist for parental consent or any other thing. So you can just go in, make an appointment, and get assessed by a mental health care professional. So really, I encourage you or anybody your friend who has symptoms of any mental illness, OCD or resultant anxiety, depression, seek help early, because early intervention makes a huge difference. Next slide. So this is what the message is about today. I am me and not my OCD. Don't let yourself be defined by your OCD. You're still the same person with your hopes and dreams, and you can achieve that because OCD is very treatable and treatment makes a big difference. So, for the people who have symptoms, get help. You're not alone. And then for your peers and the educators who are attending the forum, our message to you is be aware, get involved, encourage people to seek help. And I'm told that there are 700 people attending the forum today. So that really shows that you're interested, you're aware, and you want to get involved. So please look forward to today's morning of talks, presentations, and lively discussions. Thank you so much for joining us. Over to you, Jackie.
Thank you, Associate Professor Verma, for your speech. We're truly honored to have you here today, and we hope that you will enjoy the rest of today's program. So, as Associate Professor Verma mentioned in her speech earlier, OCD is a disorder that is very, very misunderstood by the public. There are many stereotypes and a lot of stigma surrounding this condition and its symptoms. And I'm sure all of you know this is not very ideal and can be very detrimental to these individuals. So, with this, we've prepared multiple videos that will be shown later on in the session, in which we have invited some individuals to share about their experiences with OCD. So before we start our first segment, you will see that you will be able to actually post questions and comments on our YouTube. So to access this Q&A function, right, you actually have to minimize this screen, meaning that you cannot put this like live stream on full screen. So once you have minimized this video, you'll be able to see the comments or Q&A function on the right. Okay. So once you have found that, right, you can just send in your comments or questions, and we hope that you'll be able to use this function to post questions specific to OCD. So our moderators will be trying to answer as many of the questions as possible. But do note that we actually also have a Q&A session after your presentations are over at the end of our program today. So your questions might actually be answered live by our speakers as well. The various presentations today will also seek to answer the many questions that were submitted during the registration earlier on. So with that, our first segment today is titled I Am Just So OCD, an Introduction to OCD. So this segment will include a video regarding two individuals living with OCD, as well as a sharing session by Dr. Banu Gupta. So before we continue, let us take a look at this video, which will introduce us to OCD.
I think my monster kind of look like, it's like a little fuzzy little circle ball. To me, my monster isn't really necessarily a monster in the sense that it's very scary or anything. It's sort of just a bit annoying companion that's kind of always just behind me, you know. It's sort of big because, you know, it's always there. It takes up a lot of my time and like it's sort of integrated so much into my life. So that's sort of my OCD monster. Like it's just
a companion.
Yeah, a constant annoying companion. Hello, my name is Jalid. I have obsessive compulsive disorder. I'm 25 years old this year. I'm currently doing my PhD in psychology where I'm looking at all things social media essentially.
So I'm Claire. I currently live in the States. I'm 31 years old and I'm a professor, so I teach courses on literature, particularly American literature.
So I first figured out that I was kind of having OCD symptoms when I was 13. This was, you know, when H1N1 first started in Singapore, and so, you know, naturally like everybody else, I was a bit scared of germs. I was trying to keep clean and things like that. As time went by, I realized that my behavior was getting a bit more extreme and irrational. I had this very extreme fear of dying, and I was constantly washing my hands, trying to actively avoid things that I kind of deemed as toxic or like would kill me or poisonous. I was afraid of very common household objects like rubber bands, pencil lead, rust. So I would actively avoid touching these things, and like if I accidentally touched them, you know, I was so convinced that I was gonna die. And like I would actually like, you know, count down to my death and give myself like 3 hours to live. Of course, like I mean I survived obviously, but you know, even when I did survive after the 3 hours, I still kind of convinced myself that, you know, that was just a fluke. I was gonna die the next time. And so that's when I kind of figured out, I think, because my friend, you know, I think he was trying to tease me, so he was like, actually I think you have OCD, and I was like, at the point in time I didn't know I was, so I googled it and I realized, it sounds like me.
So I had OCD symptoms as long as I can remember, going back to early childhood. It kind of manifested itself when I was young in terms of, you know, just bad intrusive thoughts. So I, you know, think a curse word in my head, like the F word or something. And I didn't know why I was thinking it, but I was like, you have to be bad, you know, if you're thinking this. It would just be a lot of rumination on what kind of person I was and why I could be having these thoughts. It went away a little bit at different points in my life. When I was in high school, I was doing pretty well. And then it wasn't until I went away to university, which is a big transition, that the OCD really exploded. And I ended up having some compulsions that accompanied a lot of these thoughts about being a bad person or thinking bad things about people.
At one point in my life when I was about 14, you know, I had very persistent and recurring images of like Jesus naked. And you know, as a 14-year-old Christian girl, it was very disturbing. Like, every time these thoughts came to my mind, I couldn't get it out of my head. And so, you know, I always left feeling very disgusted with myself and feeling like, you know, God would punish me. I also had all these very specific rituals when it comes to like prayers. The words had to come out of my mouth the right way. When I wanted to pray for my family, I had to list down like their full NRIC name and things like that. And if I did something wrongly, you know, I had to repeat the entire prayer all over again. It would take me a very, very long time to get through like one prayer. And I was convinced that like if I didn't say this prayer correctly, you know, God would punish me and kill my entire family as a punishment and things like that. And I didn't want to take that risk, of course.
So what started to happen is rather than just have the bad thought, I started to become fearful that I acted on it. A lot of people are afraid of like physically harming someone, and that wasn't the case for me. It was more emotionally harming someone. So I would worry that I left a note for someone on campus that said something terrible or racist or mean And so I started to think or like imagine that I had actually left some of these notes at different places on campus. So in order to convince myself I didn't, I would pick up the papers, and so you would find me like picking up trash on the university lawn and things like that to ensure that I hadn't actually done something to hurt someone. As it got worse, it was like I can't eat certain foods because if I eat this food, it might mean that someone gets hurt. So it got to be kind of some really illogical thinking around like protecting other people and their emotional safety. That's the thing with OCD, you know it's irrational, but you're really gripped by the fear. So then you start to believe that these things are true.
This fear for my family dying, it also kind of translated into other compulsions and behaviors that I had. I had all these specific behaviors that I had to do to protect my family. So that's why I thought so for instance, whenever I left the house, I had to touch the door lock like a specific number of times. So I had a few rules. So it had to be an even number, and it cannot be 2 because 2 was too little. 4 not allowed as well because 4 in Chinese means death. 6 was also not allowed because 666 was the devil's number. And so, it was always a minimum of 8, 10, 12, and so on and so forth. Because I felt that if I didn't do it the right number of times, like somebody was going to break into my house, kill my entire family. I really, really did not want to take that risk, and I'd rather just stand there for like 5 minutes just touching the door lock.
We have a big prominent newspaper in the US called the New York Times, and she had read a piece about a man who was afraid of hurting people, right? And that was a form of OCD. And that's not something that we don't necessarily think about OCD as a fear of hurting other people, right? We often think about it as checking or cleanliness or orderliness, and that wasn't my case at all. So when she brought that up to me, she said, I think you might have OCD. I was like, no, I don't have that. I don't know what she's thinking. But I started to do a little bit of research on my own, and I was like, this seems really, really accurate. I once had someone describe it as, it really is an overwhelming sense of fear. It would be if you imagine, watching after a toddler and they suddenly run in front of an open highway, and you see a truck coming, right? Like it's that level of fear where you're like, I need to do something right now to ensure that this catastrophe doesn't occur. I need to get this terrible feeling of fear away, and in order to do that, I'm going to do some kind of compulsive behavior. And that really defines, right, the kind of what OCD is. It's a combination of obsession and compulsion. So the obsession is the fear, and then I would say the compulsion is really that urgency, that I can make this right or fix what I believe to be wrong.
Wow, that video was really very informative and detailed video that gave us a glimpse into the lives of individuals living with OCD. So hopefully this video was able to help you to get a better insight of what OCD is and its symptoms and more. So with this, Dr. Banu Gupta, Senior Consultant in the Department of Mood and Anxiety from IMH, will now be introducing OCD and sharing about its prevalence, causes, and more. Dr. Gupta, please.
Well, thank you, Nadia. I hope you can hear me. I think all these glitches just happen when you don't want them to happen. So the purpose of my talk is to sort of try and explain what OCD is. And I think the speakers before have done some bit of the job. So what I'll try and do is just set out this context a little bit again, just to re-emphasize on how we as psychiatrists conceptualize OCD, but also to see why its awareness is important in the Singapore context. So, when we talk about OCD, commonly we think about someone who is a bit of a perfectionist or a bit of a neat freak, someone who is obsessed with cleanliness, and almost comes as a virtue. So, people say, I'm so OCD, and they are not sort of saying that in a stigmatizing manner. They're almost normalizing what is OCD. And while that is helpful, that also sometimes trivializes how severe OCD can be. When we as psychiatrists or as mental health professionals think about OCD, we conceptualize it as two distinct bits to it. So there is the obsession part, and then there's compulsion. And I think you heard the speaker earlier mentioning about the obsessions and compulsions. And then, as Prof. Swapna mentioned, it's not just about that, it's also about the distress and the impairment that it causes. So let me try and explain to you again what are obsessions. Obsessions are repeated, intrusive, or persistent thoughts, and sometimes they can be ideas or images or impulses that a person gets into their mind. So these things just enter the mind, and these are unwanted. A person doesn't really want to think about them. They're also unpleasant, which means they don't give any pleasure. The person themselves know that these are voluntary ideas or thoughts, so which means that no one else is putting it into their mind. These are their own thoughts, and they often try to resist. At some point, they try to sort of not experience these thoughts, so they may try to ignore or suppress, but then they are unsuccessful in doing that. And what these obsessions do is that they lead to increase in a person's anxiety. So anxiety is the main symptom of OCD, and because they experience this anxiety or the distress, they try to get rid of it by doing something called a compulsion, which I'll come to in a minute. Or sometimes they may try to replace it with another thought, or try to avoid getting into a situation where they may have these obsessions. And they typically happen when you're trying to think about something else. So it just kind of enters your mind even when you're busy with something else. Now, obsessions have common themes to them. And the common themes, as you know, we have already heard some of them, is a fear of contamination or dirt. So you may have this thought in your mind that your hands are dirty, or you're not showered enough or clean enough. Sometimes it's about having things orderly or symmetrical. So having things in a perfect way or just the right kind of way. It can be things which can be difficult to talk about. And one of the reasons why OCD remains hidden for a long time, particularly with children, is that some of these obsessive thoughts can be about aggressive things, or thoughts that you may harm someone or hurt someone. And also it can go on to more taboo subjects like religious or sexual thoughts. So one may do something to offend God, or have sexual thoughts which are not something that you can openly talk about. So obsessions can lead to a lot of distress. And in order to take care of this distress, what people end up doing is they end up doing some kind of a ritual, or what we call as compulsions, which are repetitive behaviors or mental acts sometimes. So it's not just behavior that you can see. Sometimes it's something that people just think about in their own mind, and they feel driven to perform it in order to reduce the anxiety that comes with the obsession. Or sometimes it's about preventing something bad from happening. Now, compulsions are clearly excessive, so they're kind of out of proportion. So one doesn't just wash their hands just one time, which is what most of us will do, but they will keep washing their hands, and they will develop a certain ritual or way of doing it. And doing these compulsions does not bring any pleasure. So sometimes people talk about, being obsessed with, let's say, games or food, and then when you start to play these games or enjoy the food, it actually gives pleasure. Whereas the OCD compulsions, they're not there to bring pleasure, but they are there to give some relief from the anxiety that the person experiences. And unfortunately, the relief is only temporary until the obsessive thought comes back again. So you wash your hands, you think the hands are clean, and then suddenly the thought comes back into your mind that your hands are dirty again. And they're often not rationally connected to prevent the feared event. So people kind of think that doing these compulsions, it kind of takes care, but sometimes they go to the extent where it just does not make sense. Now, compulsions usually have themes such as washing and cleaning. And this is sort of not just normal washing, this is excessive washing and cleaning. Sometimes people like to count things a number of times. So you have to do it 2 or 4 or 6, as someone mentioned. There are good numbers and bad numbers. You would see people checking a lot. So you see people sort of looking at their bags or checking for light switches. And at times it could be a compulsion could be something like demanding reassurance. So wanting a family member or a friend to reassure that things are right. And this reassurance can again follow a bit of a ritual where things need to be said in a certain way with a certain tone. Otherwise, it's not good enough. Compulsions can also mean following a very strict routine or looking for orderliness, which means sometimes organizing things in a particular way or being not just neat, but very excessively neat. Things are ordered according to color coding or size and various permutations and combinations. So these are compulsions. And what is interesting is, as Prof. Swapna mentioned, OCD is pretty common. As an illness, it's the fourth most common illness in the world, but it's also quite disabling. And we are talking about people who get affected to the point where they spend a lot of their time just indulging in these compulsions or thinking about or getting these obsessive thoughts. Next slide, please. Sorry, so I can't see the next slide, but in terms of the Singapore local context, it's one of the top 3 mental illnesses. And the Singapore mental health study, which was carried out, and Prof. Sapna mentioned, it showed that 1 in 28 people suffer from OCD, which is one of the highest prevalence in the world. Next slide. So the other part is, of course, that people, when they have a mental health condition, they are reluctant to seek help. And for OCD particularly, there's a very long treatment delay. And it could be because of the stigma, but also because people don't recognize this and OCD kind of just creeps in. So the median years, which means the average amount that people take to seek help for OCD in Singapore is about 11 years. So that's suffering from these symptoms for almost 11 years before you seek help. And a lot of the time, people don't seek professional help. Next slide. The other part is, of course, about recognition. So there was this study carried out in 2014 called Mind Matters, where they asked the general public, they provided them with some vignettes and checked if the public or the respondent could recognize what the condition was. And what they found was that the recognition for OCD is pretty less. Only about 28% could recognize that the vignette is referring to someone with OCD. So it's not just that it's quite commonly prevalent, but it's not very well recognized. And that makes it more complicated for people to seek help. So the question is, how is it diagnosed? And as I mentioned, there is the obsession and the compulsion part, but it's quite important to screen for OCD. And screening becomes important because not just the person themselves, but even professionals quite commonly miss OCD because a person doesn't come and volunteer their OCD symptoms. So I had a teacher who came to me with anxiety and mood symptoms. And on the face of it, she sounded quite depressed. But when we got to know a little bit more, and I asked her a little bit more detail about her routine, it turns out she was spending a lot of time trying to check and recheck her questions and the answer sheets. And she was hardly sleeping. And that was affecting her mood, her relationship, and giving her a lot of anxiety. So actually, what was OCD she didn't come saying that I think I've got OCD, and she didn't think it was anything wrong with that. But when you screen, that's when you realize that the person may have OCD. Now, there are some quick screening questions that have been devised, and these are simple things such as, do you wash or clean a lot, or do you check things a lot, or are there any thoughts that keep bothering you that you would like to get rid of but you can't? Do you spend a lot of time in your daily activities, or do they take a lot of time to complete? And are you concerned a lot about orderliness or symmetry And then finally, do all these problems trouble you? Now, if a person says yes to one of these above, then it's probably better that they get a more formal diagnostic interview. And like Prof. Swapna mentioned, uh, um, agencies such as Chat, which is a fantastic service to just access. One can go there to get a mental health screening. It's particularly catered for young people, and it's a very safe place to go without any worries about your records or the stigma that it brings. So for making a formal diagnosis of OCD, we use something called DSM-5, which is like the Bible of psychiatry, and which lists out all the mental health disorders. And DSM says that OCD means that one has to have obsessions and or compulsions, but not just that. They need to be either time-consuming, which means a person spends more than 1 hour a day, or they cause distress and impairment in a person's social, occupational, or other areas of functioning. And then it puts a few qualifiers. They should not be because of illicit drugs or medications or another medical condition. And it should not be explained by other mental disorder. There's also some further bits to it, which is whether there's an associated tic, because 30% of the OCD sufferers can have tic at some point in their life, particularly males. And then whether the person with OCD has good insight or poor insight. Now, most part, OCD was something, as I previously mentioned, that person knows that these are unwanted thoughts. But sometimes, as the condition progresses, or for some people, they don't have that level of insight, so they don't even realize that what they're indulging in may be OCD-like condition. Next slide, please. Now, OCD, other than the sort of main OCD, it also comes with its own constellation of other conditions, and we call them as obsessive, compulsive, and related disorders. And the common theme is that there are preoccupations or kind of obsessive thoughts, as well as some repetitive behaviors within these conditions. And these are conditions such as body dysmorphic disorder, where one is sort of particularly concerned about some kind of a perceived, self-perceived defect in their body, and they are quite preoccupied with it, and it's quite distressing. It can be hoarding disorders, when people have difficulty in discarding things, so they like to save or accumulate a lot of things. And then hair pulling and skin picking, or other body-focused repetitive behavior, as it is now named. And then sometimes substance and medication-induced OC and related disorder. So these are conditions which are closely associated with OCD. Now, OCD comes with a lot of other issues. So anxiety, which is one of the main manifestations of OCD, one can diagnose almost 3/4 of the patient with OCD with some kind of an anxiety disorder. And that just tells us that how much of anxiety is part of OCD. Mood disorders, so about 2/3 of patients with OCD have some kind of mood disorder, with major depression being the commonest one. 4 out of 10 will have depression at some point if they suffer from OCD. Obsessive compulsive personality, which is another common comorbidity with OCD. Now, with obsessive compulsive personality, people don't worry so much about their obsessions or compulsions. They actually, it is kind of part of their character or how they are built, and they are not distressed when they have these rituals or behaviors to do. But you can have comorbid OCD and obsessive compulsive personality. And then there is some link noted between tics, as I mentioned earlier, as well as even in conditions such as schizophrenia, where there is more than 10% prevalence of OCD. Next slide, please. One of the common questions that we get is, why does one get OCD? Is there something that triggers it? So there is a genetic component to it. So the rates of OCD is higher in first degree relatives of people with OCD, about 2 times. But if the person who had OCD, they had an onset in childhood, which means there was probably a bit of more genetic load, then the incidence can be about 10-fold higher. In twins, if they have exactly the same genetic makeup, the OCD incidence can be as high as about 57%, and 22% for digyrotic twins, so their genetic makeup is not the same. So that also tells us that even if you have exactly the same genetic makeup, there's something else that comes into play in order to trigger OCD. And what evidence suggests is that sometimes things that induce trauma, or for children particularly when they're young, even some infections can lead to OCD symptoms. Like most mental illnesses, stress can precipitate OCD or make the symptoms worse. And you often see a rapid onset of OCD sometimes with traumatic events or things such as pregnancy or loss such as a death of loved one, and then you suddenly have OCD. And the final question that my final slide is about what is the long-term prognosis. And usually people have a long-term, OCD remains a long-term condition. It often doesn't go away, but sometimes the symptoms get better and sometimes they get worse. And without treatment, about 1 in 5 can get better. And if you have OCD that starts in childhood, about 2 in 5 will have remission, which means the OCD will go away. But of course, the course is complicated by if there are other disorders or how stressed a person is. And what we also find that about 50% of people with OCD respond only partially or don't respond fully. And in the more treatment-resistant kind of cases, the level of functioning can be quite impaired. There's more risk if a person has a comorbid depressive disorder. So I think that's kind of the end of my slides, and we will hopefully take questions right at the end. But thank you, Nadia, and over to you.
Thank you, Dr. Gupta, for your sharing. We hope that his sharing will clarify some of your doubts and misunderstandings about OCD and has helped you to learn more about this condition. Also, I think Dr. Gupta mentioned earlier about the technical issues that we faced earlier, and yes, I do agree that they do come out at the worst timings. But I do hope that the rest of this forum goes very smoothly with no more glitches. So now moving on, from Dr. Gupta's sharing earlier, I'm sure many of you still have a lot of questions about OCD, in which some of you might be wondering, how does OCD develop and when do people develop OCD? So in the next segment, the seed of OCD in youth, we'll be exposed to more information about OCD in youth, including the real-life experiences of Claire and Geraldine, together with the sharings by Dr. Adrian Loh and Ms. Tan Sok Yin. So with many of you here being students or educators, this segment will be very relevant and hopefully beneficial in helping you to learn more about how OCD develops, as well as things to look out for in youth with this condition. So this would hence help in possibly identifying and diagnosing OCD at an earlier age. Now, we will watch a video about Geraldine and Claire's experience on living with OCD in their youth and how it affected their school and social life. So let us now watch this video.
I once had someone describe it as, it really is an overwhelming sense of fear, right? So it would be if you imagine, watching after a toddler and they suddenly run in front of an open highway, and you see a truck coming, right? Like it's that level of fear where like, I need to do something right now to ensure that this catastrophe doesn't occur. And so that's the kind of intensity to get this terrible feeling of fear away. And in order to do that, I'm going to do some kind of compulsive behavior. I used to have all these thoughts, which would make me really upset. And they would happen a lot in the summer, especially when I didn't have the structure of school. So I was a kid who hated summer, which is not something that most kids will say.
Of all the compulsions, it takes up a lot of time. It was very frustrating. My OCD kind of affects me in the day-to-day life, very minute things, but it sort of adds up over time. But it's like, when I'm studying, I have compulsions where I have to write letters a certain way, and there couldn't be gaps in letters, and I really use correction tape a lot of times because I was constantly rewriting words, and my main method of studying at that point of time was writing notes, physical notes, and it would take me so long to write notes for a specific chapter. And so during exam time, when time is very important. I would be constantly rewriting words because to me, if I didn't rewrite the words properly or I didn't like fill up the gaps in the letters, I would fail the exam. And I think that was a risk that I was willing to take, like to not complete the exam rather than to fail the exam. I kind of dealt with it in my own way where I knew that I'll take very long to write my notes, so I would start like a bit earlier. I would give myself like sort of allowance to engage in my compulsions.
I would tell my mom, she's the only one I would talk to. I would tell her some of it, but not all of it. So I didn't really express the severity of what I was experiencing. I just kind of gave her a little bit of a glimpse into what was happening. I told a few friends when I couldn't go back to college why. And I think, we were 18, 19 at the time, so young. And a lot of them, I think, couldn't like grasp really what I was saying. So they were just talking about moving into college that year for themselves. And I felt very isolated, right? Like because I couldn't partake or join that experience. So no one said anything hurtful, right? Like I didn't get any like, oh, you're crazy or, any kind of like really negative reactions, but there were these kind of like silent responses that actually told me quite a bit about what people are comfortable talking about and what people aren't comfortable talking about, people that can't do things that they're able to do.
I was very lucky in that sense that like my first onset of symptoms, they were very stereotypical OCD, where I was very afraid of germs and wanting to wash my hands all the time. So, my friend was able to kind of identify, Chalene, haha, you have OCD. So, for me, it was easy to identify it from the very beginning.
But I certainly have hidden the condition from a lot of other people in my life at other points, especially at university. I didn't want people to know what was happening. So I became very good at acting upbeat when I had to and then doing the compulsions when I hoped no one was looking.
I didn't really know how OCD really affected my career or my life or my education because I've had it since I was like 13. So it's been like a good 12 years since then. And so, I've kind of never really knew what my life was about OCD. To me, OCD has always been there, and like I didn't seek help until much later on. Even knowing that okay, this is OCD really helped me to sort of gain a better understanding and cope with my symptoms a lot better because I was able to do more research about it. I was able to find out about other people's experiences and not feel so alone.
The thoughts are so strange, right? I mean, even just describing me running after like a cough drop wrapper on my campus, right? Like it's very bizarre, right? If you tried to explain that to someone, they would kind of start to judge you and wonder what exactly was wrong. If I had to tell people that, oh, I have OCD and I had to drop out of college, they'd be like, oh, OCD, that's not too big of a deal. Like you're making too much out of this.
I think it's very common for people to make jokes about OCD. OCD was always being thrown around very lightly. People always say things like, "Oh, you're so OCD." They always used it as sort of an adjective or sort of like a joke. But growing up, it was very difficult for me to hear these kind of things because I was going through so much behind the scenes, and like there all these people, they were making fun of it. It's very debilitating sometimes, and it's difficult to go through all that and then have people not treat it as seriously as it should be treated.
I fear that people would think I was dramatic, right? Or acting like OCD was a much bigger deal than they perceived it to be, which is of course not the case. I felt a lot of stigma and shame growing up with it.
I've learned to just get used to it. Like I know it's not what everybody goes through, but it's kind of what I go through and what I'm used to.
As I've gotten older though, I'm in my 30s now, I've met a lot of dynamic, wonderful people who've experienced all kinds of struggles and they take my own struggles very, very seriously as I do theirs. And so that's been a really important growing experience.
Wow, we hope that you really enjoyed that video. So it really gave us all a glimpse into the real-life experience of an individual living with OCD. And being able to hear these real-life experiences was truly eye-opening and insightful. Now, as mentioned in their video earlier, it is evident that it is crucial that educators and staff in schools provide sufficient assistance and guidance for students and provide the support for early identification and intervention. So with this, Dr. Adrian Loh, visiting consultant in the Department of Developmental Psychology in IMH, will now be sharing more about OCD in youth, including its significance and effects on youth. Dr. Loh, please.
Hi, good morning, everybody. Hope you can hear me loud and clear. I think it was really awesome to see the video just now, and I just want to really say thanks to Jerlyn, to Claire. It was really brave of them to step up to be able to share their real-life experience. I'm also just guessing that means among some of you here, perhaps some of you have met me before. perhaps you've been in my clinic. Just want to just say thanks to all of you because I've learned so much about helping people with OCD because of you. I also noticed in the chat that we have people tuning in from Malaysia, from Thailand, and probably other parts of the world too. So happy that you'll be able to join us today, perhaps due to the wonder of this live streaming. And finally, just want to just give thanks to Temasek Poly, to OCD Network, to partner us in IMH to be able to bring this to you today. Okay, so earlier on, you heard Dr. Swapna and Dr. Banu give a wonderful introduction to OCD and how it's such a common illness, how something that affects so many people in Singapore. Right now, I want to zoom into how OCD actually really affects our youth, and hopefully that will be a good starting point as later on my colleagues, including Ms. Tan from Temasek Poly, will be sharing a bit more about how OCD happens to our youth and what we can do to help them. Okay, so for OCD, when does it actually happen? So what we do know is that OCD frequently happens in two very prominent age groups, which where it tends to peak. Okay, that would be the late primary school years, and then also the late teenage years. So for the late primary school years, for those of you who remember, there's the time of your upper primary and maybe around your PSLE years. That's often time when we meet people in the clinic, we find that that's a time where the OCD symptoms occur. And also another peak that, as I mentioned, was in the late teenage years. And that's the time that they're going through major exams, the stress of national service, and going on to tertiary education. So these are the two peaks that we observe around the world as well as in Singapore. So I think for many of you here today, you are in your late teens, early as young adults, and you'll be able to identify with these peaks of onset. That said, I just want to highlight when we talk about peaks of onset, it helps us to be able to make it a bit easier to make diagnosis, but at the same time, it doesn't mean that in between people don't get these symptoms occurring and starting then. So why is it important to know that OCD is something which occurs in frequently in youth, and the peak is it occurs at the late primary school years, the late teenage years? Or what we do know is that aside from actually being such a major effect upon our youth, we actually do know a lot of adults do present with OCD, not just at the point in time that they come to see us as adults in their 20s, in their 30s, in their 40s. But as Dr. Banu earlier shared, many of them actually have taken a long time before they decide to seek help. So we actually do know that 30 to 50% of people report a childhood onset of OCD, only that they decide to seek help much later on. We actually refer to this as a treatment gap. And as you can see the iceberg picture there, what that means is that oftentimes the people that we get to see in the clinic or our colleagues in the community are trying to help only represent the tip of the iceberg. There are many people out there in the community who are continue to experience OCD symptoms. They either don't recognize it or perhaps they don't want to seek help for it. So that's what we call a treatment gap. And we do hope to, by opportunities such as today's talk and other ways of helping the public understand more about OCD, we'll be able to encourage more people to step forward for early diagnosis, early treatment, so we can reduce the effects on their life. Okay, so maybe for youth, what are some of the difficulties we can experience that as compared to adults? So one thing when I say youth, is quite a broad group. It can actually start, of course, from the late primary school years, as I mentioned earlier. And I think probably not many of you here today are in that age group, but majority of you will be the late teen years. And yeah, so what are the things that we're looking out for in trying to make diagnosis in this age, in the youth age group? So I think Dr. Banu, my colleague, has really shared a lot about the symptoms earlier on, and if it was just too much to absorb, I just invite you later on to review the YouTube video again and just to go through all the information that was shared. And what I think that some of the things to highlight is that many of the symptoms which occur in the younger age group, especially in the primary school and the early secondary school age, they can be what we call developmentally normal, meaning that even other children, other teenagers may actually have similar kind of symptoms, and that may not necessarily mean that there's actually a OCD condition. So what are some examples of this? For example, I think earlier on, I think Jerlyn mentioned about some of her school-related kind of symptoms. Yeah, so oftentimes in school, we may be conditioned, or we have been encouraged to be very careful about our work. So we are told to double check, triple check, multiple check our work. So when does checking of work become something which is compulsive in nature, as opposed to just being conscientious and doing your work diligently? So checking your work may be one symptoms to check that we need to verify whether it's something that's OCD related. For some younger people, they have certain ways of doing things And one example would be how they step on a pavement or how they touch certain things around them. And these are quite common in the early years. So, and even children without OCD, young people without OCD may actually have such kind of behaviors. So that can be a bit confusing. So sometimes for us as doctors and psychologists trying to help, we need to be able to differentiate what is sort of like a normal development versus something which is turning into an OCD. And then, of course, the presence of what we call cleaning rituals, I think is very highlighted, especially in this time of COVID. And we are all urged to have all sorts of hand washing rituals. We are urged to be extra clean, to clean more surfaces. Now, so when is that going to be something which is normal versus something that develops into what we call actual OCD? Yeah? So I think this is where it's important to compare with peers. While we emphasize that each and every person is an individual, they have different life experiences, I think it's very valuable to be able to just maybe just have a to be able to ask other people around you or your friends, or and if you're a parent or educator, to perhaps also look at other people around the student in question. Are other people around that age, the peers, do they have similar kind of behaviors? Because if something that the child is presenting with is actually also being done by everyone else, then there's less likelihood that that's actually OCD. However, if everyone else around them is not doing that and they're doing that a lot of that, then I think that does point towards it is becoming excessive, and the excessiveness is a feature of OCD. One other difficulty we have for youth is that they may have a difficulty describing symptoms. Okay, and they actually. So first of all, imagine if you're having all this double checking, triple checking, or even like maybe checking your work 10 times. You may not actually. We say you may have limited insight, and then what that means is that you may not even realize that that is something which is excessive. You may have come to think that that's just a normal that's required. And also, even if you were to do some of these kind of behaviors, how actually do you actually describe it? How do you tell people that you are, for example, the example earlier on I was talking about how people have a certain way of stepping on pavements, maybe alternate colors and all that, or having certain, Dr. Bano mentioned about having certain special numbers, maybe things have to be in multiples of 2 or 4. How do you actually describe those symptoms to other people? Because you might have difficulty describing it, or if you describe it, you may think that people will think that you are that will ostracize you because you think that it's weird. So that's very difficult for our youth. So because of that, it may actually lead to a delay in the diagnosis, a delay in seeking help. Another difficulty we face in youth is that partially because of the fact that our youth are really transiting from childhood into adulthood. So, and everyone has a different developmental trajectory. So in a sense, some of the early what we call developmental changes and all that may also overlap with actual symptoms of OCD, and they also overlap with other common conditions that occur in the age group. So a very common one would be what we call tics. Okay, so for tics, they actually have this. We know that 30% of children actually may experience tics, and these are actually sudden twitches, movements, or sounds that people do repeatedly. And ADHD, attention deficit hyperactivity disorder, that's also another common condition that often co-occurs with people who have OCD. ASD, autistic spectrum disorder. Now that's a condition where there's quite a fair bit of rigidity, quite a need to stick to certain routines. So sometimes the OCD sort of symptoms, the compulsions and all that, they can overlap a lot with the need to be able to stick to certain routines, which we see in ASD. Anxiety conditions, depression, those are also very common co-occurrences with people who have OCD. And what do you mean by early psychosis? Well, early psychosis, that actually refers to the early onset of unusual symptoms that may possibly link. Can I go back to the last slide? That may actually point back to the later development of conditions such as schizophrenia. So we do know that up to 20 to 25% of people with schizophrenia or early psychosis may actually have symptoms that look like OCD in the early stages. Also, many people do have eating disorders. So I think that's just really a listing of possible conditions. But I think we really have to, after this talk, I think really meet up with your counselors, your clinicians to be able to discuss a bit further about these areas, because it is just for each and every individual, there's just so much variations. Okay, next please. Okay, I want to discuss a bit about the effects of OCD upon all of you, those of you who are tuning in who suffer from OCD, as well as your parents, your caregivers, and educators. Now, I'm going to first of all talk about what we call rage attacks, or maybe another word for it is just anger attacks. And I think this is not probably a word that you are familiar with, and it is a word that has been used by people who study OCD, who work with people use OCD, and it describes that phenomenon whereby somebody has episodes of explosive anger that is triggered by just really seemingly minor kind of provocations. What might that look like? So I remember one of the youths who came to see me in my clinic. His parents were just so in despair because at home everything in the house had to have a certain symmetry and a certain position, and if it was moved out of order, that that youth who in the past was a very gentle, loving child would get into a huge rage about his parents moving the kitchen equipment out of order and all that. So that's what we call a rage attack, and it's very typically it's quite out of character for the child, quite different from what he or she was like growing up. So we call that rage attack, and it does have play a major part in uh, causing distress to our youth. And leads on to our next point. Because of all that kind of symptoms, sometimes later on you hear from my colleagues that this actually leads to family needing to adjust to that kind of sometimes to accommodate the OCD, and even not just the parents, siblings at home, they may all feel very resentful of this OCD, or they may start to really unfortunately, even blame the youth himself or herself because they think that this is something which they want to do when actually it is OCD making them do it. So it leads to disruptions of family life. I know some of my patients who see me in the clinic, they've suffered from such a disturbances to their family life. So that's really something we really need to address. Okay, another major issue is that of stigmatization, which I think you've heard from Jerlyn and Claire earlier on talk about how other people treated them after they had these OCD symptoms. Now, this may of course, lead to a reduction in your self-esteem. And of course, it may also, in the school setting, we are aware that bullying is a major issue in schools. And nowadays, we talk about cyberbullying because it doesn't have to be something which other people can see. It just happens all behind the convenience of a smartphone where there's a lot of bullying that can happen. So yeah, this can take the form of name calling or perhaps people posting photographs that are teasing towards the youth who's being bullied. So these are common consequences of people who are having OCD. Academic problems. Now, academic problems are often many of our OCD, many of the youth we have with OCD, they're actually very conscientious individuals, and they actually have good performance in school before the OCD starts. But what happens is that when the OCD begins, and especially when they're not seeking help, often they compensate by spending more and more time doing their compulsions. And I've known some of my patients who see me in the clinic, they can spend a few hours attending to their daily rituals. I imagine that we know in Singapore already there's quite a fair bit of homework to do, quite a bit of academic demands. If you layer on the need for youth to be able to attend to the OCD rituals, spending so much time on it, then naturally it will lead to distress in the area of the academic. They won't be able to keep up in the school. And as like for example, someone who needs to check very often, they may have difficulty even submitting their schoolwork and all that because they're just unable to meet the time limits. And of course, the presence of all this distress will then also increase their vulnerability to other conditions such as anxiety, depression, and of course, we have to be very mindful, don't we, that even of suicidality and all that's something that we are really concerned about as a nation. Okay, so I just want to having a touch on about how OCD may look like in the youth and how people who have OCD, how it may actually affect their lives. Now, I'm zooming in really, I guess, to the educators, to the counselors in schools, but it also applies just as much to parents or anyone else who's trying to help a youth. What can we do? Okay, so the first thing I would just say is that really you want to validate the distress and not to dismiss it. Now, it's very, I guess, easy nowadays to say phrases like that, but what does it actually mean to validate a youth's distress? So what will happen is that frequently they may actually bring up their symptoms. And if you recall earlier on, there was mention about how OCD is a condition where the symptoms can be illogical, irrational. So I think the important thing is that if you're hearing a youth out, just listen to them first and just identify with the distress that they're experiencing without saying that, oh, no, that can't be possible, or saying things like, oh, that's just, no, just as crazy, and, oh, no, it's clearly illogical, just stop thinking that way. So I think that's what we do often encounter here. We hear our youth telling us that people don't understand. So just validate. I think that's the first step. Now, oftentimes also when we're trying to help our youth, we may often, because we're now out of good intent, we may zoom in upon the problems they're facing. I think that is important. But at the same time, I think each and every one of the youth that we help, they actually do have many strengths of their own, be it probably they have a talent, they have a certain ambition in their life. Let's try to work along what is their strengths and not just a focus upon their difficulties. We also want to reinforce what we call psychoeducation, meaning that to help the youth understand about his condition. Because oftentimes, and I think in our clinic setting, it can be a bit busy admittedly. So sometimes, we have to rush through so much information. So if the educator can help us by just trying to reinforce what OCD is about, that can be really valuable. And also sometimes, if it's appropriate and the youth is willing to share this with other people, then you may want to consider getting her permission to extend the information to other students, or even the teachers, so that they can also keep a lookout. And this is not for the purpose of trying to stigmatize that person, but really to allow them to help him or her. Be on lookout for bullying from other youth, and where appropriate, some schools, some polytechnics do have peer mental health support ambassadors. Yeah, consider tapping on them to provide additional support to our youth who are trying to fight that OCD. Next. Okay, now, so really, what do we need to do about OCD if as a team? So there's the educators, the counselors, the psychiatrists, psychologists, counselors, and even the parents. So what we want to emphasize, we're all on the same team playing against OCD. Because as I mentioned earlier on, a lot of the distress in the family setting happens because the parents, the siblings may misunderstand that OCD is actually, the child is OCD and he's responsible for what he's doing. What we want to emphasize is he's responsible for seeking help, but OCD is the enemy. So everyone's playing on the same team. So likewise for the school educators, school counselors, let's remember we're all against OCD, and to reinforce to our students that that's where we are. That's what we're trying to do as we support them in the school environment. Yeah, another very common area that does come up for us as doctors and psychologists is trying to help our school colleagues, the educators, the teachers. How can we help them in the school setting? So one of the common ways is actually to look at, do they need some sort of accommodation? And by accommodation, the common areas may be, for example, extending a submission deadline, providing special exam venues, maybe they need to be alone, or perhaps providing some extra time. Now, each and every one of these accommodations are quite individualized. We don't want to give a blanket one-size-fits-all for every youth who has OCD. I do want to stress, though, that this is really, we do want this to be helpful to them and not something that would be required permanently. So we really want to review this from time to time, and we try not to go for long-term accommodations, but really to look at it maybe at it 1 year at a time, and with the goal of trying to help the individual to recovery so that they can slowly have some of these accommodations removed, allowing them to complete education just like any other of their classmates. At the same time, though, as we provide these accommodations, let's try to help them see that this is something that is not meant to make them feel different or feel stigmatized, but really a way to allow them to not to let this enemy of the OCD interfere with their academics. Now, so for some of our youth who are seeing a psychologist, oftentimes one of the major treatments that we give for them is what we call exposure and response prevention, ERP. So there's a very good ERP plan, and especially some of the symptoms relate to schoolwork, as I mentioned earlier, checking of schoolwork, completing, making sure the letters are formed perfectly, making sure that other people are able to, don't process. Some people are less conscious of other people, what they're looking at them and all that. So a psychologist who has an ERP plan for the youth can actually share this with the school, with the youth commission, and the school then can actually consider supporting some school-based exposures. It could be in the area of, for example, setting a maximum number of times the youth is allowed to visit the toilet, because he may go there to attend to certain rituals when he feels that the obsession of cleanliness comes in. So the school can actually help by monitoring these areas and reducing some of these visits, so as to help him in his not to keep on giving into that obsessions. Okay? So, but of course, this requires a very case-by-case approach, and please don't rush into trying to do ERPs with your youth without consulting the psychologist or the mental health professional who's helping the youth. Maybe a final point I want to emphasize that many of our youth will actually benefit from being on medications. Admittedly, it does take some time sometimes for us to find the right medicine, the right dosage, but oftentimes it will help. What I really do hope our educators or counselors in school can do is to continue to encourage them to be adherent to their medication, to follow according to the correct dosage, and importantly, not to discourage them from taking medications. I have, unfortunately, in the course of my time as a psychiatrists helping young people, come across some well-meaning teachers who would actually tell their students, or try not to take the medicine, or maybe bad for you, or something like that along that lines. Yeah, so I think it's well-meaning, but often, as you can see, that will actually could be detrimental to the treatment required for the youth. So if you're a teacher, you have some concerns about medications. If you are a counselor, you think that it may be giving them some side effects, what you can do is actually contact the psychiatrist with or prescribing the medications with the youth permission, or perhaps maybe just ask the youth to discuss further about this with the psychiatrist or doctor helping him or her. Okay, so I think right now I hand over the time to Ms. Tan from Temasek Poly, and she'll be able to expand a lot further on how we can help our youth in school. Thank you.
A very good morning to everyone out there. My name is Sok Yin. I'm actually a counselor with Temasek Polytechnic. And many thanks to Dr. Loh for his very insightful sharing earlier. And there were many tips that actually covered about helping you, a student, in school. So what I'm hope to do for this next about 10 minutes is really to just help to give a different point of view slightly regarding a youth who is experiencing OCD in school, and what likely could be the kind of experiences he or she may have, and then also how people might be seeing them and the kind of difficulties they could have probably in knowing how to attend. And last of not is later to share a little bit how can this collaboration and network be put together to really support a student. So let me first speak with you on the story of Alan. This is, of course, not the real name, but I'd like to share that Alan is a youth that's commonly seen in solo since his orientation or induction into the institution. People notices that he is always on his own, and sometimes during sessions or lessons, he would need to go to the toilet and he would go for a long time. When asked, he would not explain much. In fact, he tried to kind of wave it off, not having to explain too much. Then when others go for lunch and ask him to join, he would not join. And later on, people will stop asking to join them. And working with group works, others would suggest places to meet, time to meet. But Ellen would want to ask, can they meet them online? But sometimes he will agree to go along, or he will ask to join in from video call. When even though it was arranged to meet online, then he'll just kind of join in from video call. And even when they meet in school, it's quite common that he may be late, or sometimes he will lastly call in and say he could not turn up. Again, when people are trying to ask, like, what's going on? Is there something? It will be very hard for him to explain. So when all this is happening, what others do not see is perhaps the time spent for this youth or for Alan to fight the obsessive thought. He could be struggling with cleaning, struggling with packing, struggling with just getting out of the house. What others really do not see is the struggle behind the efforts to gain control, and also the shame of not able to explain very well and letting people understand. Maybe we go back to the previous slide. So what people are seeing more is a youth that has kind of a weird temperaments, and in some sense inflexibility, and also on top of that, kind of disrespect of others' needs and always focusing on himself, his own needs, and being very self-focused. We go to the next slide. So with that, we could actually see and really not understand what Alan could be going through. Alan is not a real name again, perhaps, and I mean, I share here, it's not a real person, but what the challenges that is faced by Alan is very common for youth with mental health as well as OCD. He or she likely have difficulty explaining very clearly what he or she is going through, because they are also having difficulties understanding what is going on, even though they could have been already known and diagnosed with OCD. And if they have not been diagnosed with OCD, that's even worse for them to know how to explain for themselves. So shame will be very commonly how they feel, not knowing how to explain, not knowing how to gain the acceptance, but only aware of their struggle. And at the same time, I think been spoken earlier very much is about the stigma of mental health, with many people still having different ideas about mental health, even sometimes still viewing it as a person being hopeless or no more worth if they have a mental health condition. Students will be very, very difficult or very apprehensive in sharing about their difficulties. And with these psychological challenges, you could imagine that they may have difficulty concentrating, because the thoughts are just so obsessive. It will affect their concentration in class, in doing work. And so, and at the same time, with all these psychological challenges, it also translates to social challenges. As you could see that their friends are probably, or the peers and classmates could have difficulty understanding what was happening behind the scene. And so they will leave him alone, or they will think it is really very hard to work with. And therefore, that social disconnectedness as well as sense of rejection can easily be high. And not undermining medication, which earlier also been spoken by Dr. Loh as well as Dr. Banu about sometimes medication is something that needs to work on. There are side effects. And so with the side effects, that could be even increased difficulty. So with all these difficulties in place, we could imagine that a student that struggles with OCD will have a lot of difficulties in staying in class sometimes, joining in learning sessions, and therefore absenteeism is one sign that easily comes up. And if we don't check in on that, of course, it will lead on to inability to catch up in work, drop in grades, and eventually, if it's not being wrestled in time, reined in time, the student might also consider dropping out. So these are things we try to intervene and stop, or to extend help. And so the way that in a school system, what normally happens, it really takes sometimes, especially for cases that have not been diagnosed previously, a lecturer that noted the signs and symptoms of especially like absenteeism or inability to cope, to caringly check in with a student, and with a kind of nurturing, check-in, non-threatening way of approaching, allowing the challenges to be surfaced. And so commonly when a lecturer can do that kind of check-in and then discovered that there are more things that meets the eye, they send students for counseling, and we could open up a lot more situations and maybe help support students for further referral, and that starts the treatment process. In the other way, we also have students who probably have been diagnosed previously, and when the family or the students is keen to approach the helping team, the support team for help, and to open up the challenges, we could work around how to build a support system in school. So the first point of collaboration between family, counselor, and academic team is most important. Whether it's diagnosed or not, there needs to be the understanding and the communication together to acknowledge the challenges that is happening in school or could be happening as a student with OCD is being inducted into the institution. So when the communication is in place, there's a lot more prompt understanding of challenges and to work around these challenges. And the next point is really understanding acceptance of the challenges. What family may not see in school, what the school may not see in the family. But sometimes all these are quite interlinked. Because what happens in the family, as shared by Dr. Loh earlier regarding the challenges at home, the students could be going through a lot of difficult relationships due to all the conflicts. And when they come to school, it could also be difficult for them. So understanding and having in mind the context of all the challenges will help one to know how to support the student, being aware what are the challenges, and even also being aware what are the upcoming challenges in school, like quizzes, tests, and things that could also be stress-inducing. So then that could form some form of acknowledgement, and the acknowledgement will help students to know that their needs are being known, and to know that they can talk about it and can share about it. And then we can, the academic team and the support team can together think about ways to support the student. And one other ways of really helping the students is also having some peer helping in class. It could come in the form of buddy system. If the student has some a classmate that is slightly more approachable or able to relate better. So when we have someone who is able to support the student, perhaps the student will not feel as alone. So of course, we will work with the student to know how to support the classmates or for this buddy to know how to support the student, so that the buddy also know what are the ways in supporting. So then we continue to form a bigger network of able to help the student with OCD to get supported. Last but not the least is really the possibility of accommodation. I think earlier on, Dr. Loh also mentioned about certain accommodations like exam places or even timing for exams and different things, what I also want to share is sometimes there may be need of accommodation in the form of reviewing the study pace. That could involve sometimes dropping of subjects because of the condition of students that is going through the challenges. It might be really hard to battle in their mind, and we all know that time is an issue in this battle, because my students' mind is very affected by the obsessive thoughts. The checking and the various rituals will affect the time. So in view of that, sometimes having a heavy modules or coping with a full load could really be difficult. And we want to really encourage parents and students themselves to rethink that whether it's really the right timing, or should we continue in the race to try to compare with others, to continue with this heavy load. It could really mean a time to really put time apart to really handle and manage on health. When the health could be stabilized and managed, the performance is a lot better. So we would like to encourage sometimes to relook and have an open view in regard to the load of studies, and whether to slow down the pace so that a student could give ample time to work on the health matters, to stabilize and work through these obsessive difficulties. And then meanwhile, still coping with studies, but have a lightened load. And sometimes there may also be a need to even take a gap year to really give attention to the stabilizing of condition. There are actually many cases that we have come across that students, after taking a gap year, and of course using the gap year to very strategically work on coping, work on recovery, rehabilitation, that when they come back to campus, they actually score really well. So it is really about how can we look at an open view on what to do the right thing at the right moment in supporting a youth, a teenager, in continue to pursue in their future, and not to be a bit hard up on the timing currently in the competition. So if we can all do this together, it really will help a student to be able to cope, recover, and later perform. And with this, I just want to quote from the SG United this year as they fight for the COVID-19, that together we can really brave it. And as a community, when we are understanding and able to work around, understand the challenges of a student, we can actually work out an environment to help the student to recover and slowly work towards their utmost performance. So with this, I want to end my sharing and hand this time back to the MC. Thank you.
Thank you, Dr. Loh and Ms. Tan, for the very insightful presentations. So as mentioned by Dr. Loh earlier, youths are at a very vulnerable stage of their lives in which they are continuously learning about themselves and figuring out their self-identity. Youths are also easily influenced by the people around them, where the words and actions of these people around them, like their family and friends, are of heavy importance. So with this, it is essential that educators and school staff can provide the necessary support for students, especially emotional support, such as guiding them through this self-exploration journey, and possibly identifying or diagnosing any mental health conditions as well. Ms. Tan Sok Yin, the Senior Manager of the Student Support and Career Services in Temasek Polytechnic, also shared about the challenges faced by students living with OCD and the need for a strong and proper support system. So she also gave us an insight into the education sector and how educators and fellow students can better support these individuals with OCD. So with this, we'll now move on to another video prepared by Geraldine and Claire, specifically addressing how educators can better support students. So let us now watch this video.
It's so important for people to know what OCD is, right? And also people who are helping, especially first years in a university, transition to that environment, to kind of be aware that, you know, often different forms of mental illness manifest themselves in that stage, right? Because it's the first time you're living on your own, you're confronted with an entirely new environment. And so anything that's like latent is gonna come out in those moments. So having, you know, counselors, other university people know some of the symptoms and signs of OCD and have that information to students, I think is really important. I know that, you know, the first time I went to the counseling center in college, the first question they asked me is, do you wash your hands a lot? And I said, no. They're like, okay, we're just checking. We want to make sure you don't have OCD, right? So there's such a narrow conception of what OCD is, you know, and I think if we're, you know, able to actually dispense all this knowledge about how, like, OCD is both very, you know, like wild, and that there's so many different manifestations of it, but the general theme is the same. So once you understand how it manifests in someone, it makes a lot of sense. And so trying to get that information out.
Okay, so this was my second semester. And so, you know, it was the first week of school. I think she was my abnormal psychology lecturer. And, you know, this was our first abnormal psychology lecture that we were going to. And so, you know, like during the whole lecture, she was talking about, you know, different mental health conditions and like giving us an introduction about the cause. And, you know, before that, I've never really sought help for my OCD symptoms, even though I always suspected and kind of knew that it was always there. I've never really sought help for it. So, you know, when I was teaching about abnormal psychology, I thought to myself, okay, I feel like she's the best person I can ask to and approach for help. Yeah, because, you know, she was my teacher before that, so I kind of knew her and she was always very nice. So she was kind of a supportive figure that I felt that I could trust and go to. Yeah, so I remember after the lecture, I went up to her after class. I was like, hey, I think I have OCD, but I don't really know what to do about it. Yeah, so she very nicely, she was like, okay, see me in my office. And so after that, you know, it was for the next 8 months, you know, she saw me every like week or like every 2 weeks. You know, she would go through, she would talk to me about anxiety and OCD and try to help me understand the condition a bit better. And also, you know, she would teach me different techniques that I could use. So she taught me like mindfulness techniques and breathing techniques and things like that to help me cope with my OCD and also like the panic attacks that I was having at the same time.
In terms of educators, one of the things I think a lot about is never assuming that kind of some form of disability isn't in your classroom, right? So you always want to assume that any student coming in might be dealing with something, right? I think often in university spaces, we tend to think about, you know, disability as something we don't want or something we have to accommodate to fit this norm of students who aren't disabled, right? And instead, like a lot of the work I do actually in my own professional life, I study disability studies, which is a kind of new field that thinks about not only like representations of disability in literature, but also how disability functions in higher education too. So one of the things we talk about is you really want to welcome disability into the classroom, right? Like if we assume that everyone will do things in different ways, it actually revitalizes, you know, the way that we think about teaching and learning, right? So offering students multiple ways to complete assignments can be really helpful. Also at the beginning of class, I have an accessibility statement, right? And so some of that is like legal language about accommodation, but I think it's also a place to really emphasize that you want to make your classroom accessible, right? And what does access mean for you? That means, you know, whatever kind of learning need someone has, you want to make sure that need is honored and taken care of, right? And encourage students, whether or not they officially have a disability or not, to come talk to you if they're struggling with any element of the course, and being flexible in that regard, whether it's deadlines, you know, forms through which they discuss things. We were talking yesterday about OCD in school in the support group, and a lot of people have trouble getting to class on time, right? Especially if they have a lot of compulsions, checking compulsions. So finding a way even for students to be able to, you know, attend class virtually or make up some missed portion of the class if they can't arrive on time, right? All these things actually make the classroom a much more vibrant space where, you know, a whole host of populations that otherwise wouldn't find themselves in a university space, get welcomed into.
Yeah, you know, she was always a very supportive and very nice person, and I'm very thankful that I was able to have a chance to meet her and for her to help guide me through like one of the most difficult times of my life.
Wow, the video really highlighted how the people around Geraldine and Claire supported and helped them with their condition and daily life activities. So it's very heartening to hear about the support systems that they have in their lives and how it really impacted the way in their entire journey and just how they were able to cope with this mental health condition. So the video once again emphasizes the importance of educator support for students. And from all these presentations and videos so far, it's evident that this knowledge on mental health conditions such as OCD and the various ways to help these individuals is crucial in schools and learning institutes to ensure that students can receive the necessary assistance and guidance that they need. Now, you may still be wondering what next then for these individuals with OCD? What treatment options are available for these individuals? So for our next program, we'll be having the Prisoners to Our Minds Treatments for OCD segment. So this segment will focus on ways to treat OCD and how these individuals can manage and live with the condition. So to start, we have Dr. Lau Poon Tia, consultant in the Department of Mood and Anxiety in IMH, to share more about the available medication that is offered to individuals with OCD. Dr. Lau, please.
Thank you, Nadia, and good morning, everyone. So I'm going to spend the next 10 minutes or so just taking us through, a bit of information about treatment of OCD. You'd see then that I think I'll go through a few different information about the medications, and my colleagues will touch on some of the rest. But I think I just want to highlight though that the main thing I suppose that we are all here together today is to really understand more about the illness itself, but not just understanding, but being able to keep an eye out then for ourselves or people around us who may be suffering from mental health conditions, and in today's context of OCD, and understanding then the resources that's available, the treatments that they can get, the support that they can receive, and link them up, and this really sort of would be very, very helpful for either ourselves or people around us, our loved ones with OCD. And certainly, aside from medications, I'll talk about, my colleagues will talk about psychological therapies, family interventions, and how to cope with family accommodation. We have peer support specialists who are recovered patients experts who are actually able to journey with patients who are who have OCD, and through their own lived experience, being able to support in a much sort of more personal and supportive way. And certainly, of course, while we talk about treating OCD, we must not forget that we are also working with a person who may have other needs and issues and complexities, and managing all of these would be very helpful to help the person recover. So let's talk about the treatment in general for patients with OCD. I think we know that it really depends on the severity, and by that I mean how much symptoms one is experiencing, how much distress this causes to the person, and how much impact it has on his or her life. Like for example, here we are talking mainly to students, and the academic performance can be quite severely impacted as well. So if these impact are mild, then we can think about using maybe cognitive behavioral therapy, which is low intensity, or even just starting out with self-help materials and seeing how these can improve the symptoms. But certainly when it is more than mild, then we need to think about actually going for formal, regular cognitive behavioral therapy. Really think about having medications or a combination of both. And certainly for some of our patients who may not respond, to the above treatments that we talk about, we also want to consider other types of approaches. We could be using doses that are higher than usual. We could be using a combination of medications. We could be using other medications. For example, I'm going to talk a lot more about antidepressants later. And antidepressants, as we know, are the mainstay of treatment. They are the main options for treating patients with OCD. But there are other medications as well that we can use to improve the effects that they have on OCD. For example, other groups of medications like antipsychotic medications, mood stabilizers, and so on. So there are a lot of different choices that we have as well. And we also have other biological treatments that are not medications based. These could be directly stimulating the brain in different ways, including treatments like repetitive transcranial magnetic stimulation, or TMS, or deep brain stimulation, and so on. So I think suffice to say there are many different treatment modalities and approaches, and these really needs to be customized for the individual. So I have listed a few very, very common antidepressants that we often use for patients with OCD. And if you are familiar with some of these, or you may have seen people taking these, the one of the most common would be selective serotonin reuptake inhibitors, or we call them SSRIs for short. These are medications which really helps to boost some of the chemicals in the brain to correct for the chemical imbalance that we know are responsible, at least in part, for OCD. There are 5 common medications, and I think the side effects and the all that differs for the different types of medications, and I would not go into it too much here. But aside from SSRIs, we have other classes of antidepressants, and I just merely listed 2 of them. There are a lot more other sort of antidepressants that may sometimes be helpful. Clomipramine, I think someone has asked that question just now. It is one of the most effective medications that can be used to treat OCD. One of the difficulties for it, though, is that it does carry a slightly increased side effect profile compared to the first line SSRIs that we talked about. And venlafaxine is also another common medication. Next slide. So I would like to then just go through some basic principles about treatment of OCD in terms of medications, because these are also questions that are commonly asked by people when we offer them medications. They'll be thinking about what is the most effective dose, because obviously, most of us would like to take medications at as low a dose as possible. But what we know for the treatment of OCD is that it typically requires much higher doses as compared to doses for the treatment of depression itself. So it won't be surprising that people who undergo treatment for OCD often require slightly higher doses. The length of treatment is also longer as well. So we know, I think someone has asked just now as well, what is a good trial of treatment? At minimum, we want to give a person with OCD a dose as maximum as tolerated, and trial this for at least 12 weeks to see how effective it is. And certainly, if it is a mild, short-lived first episode, we could try it. We could treat the person for about 1 to 2 years after recovery. But if this is a OCD that keeps recurring, then we want to think about long-term medications, not very different from what we have for other chronic illnesses as well, such as things like hypertension, diabetes, and so on. And the maintenance dose really would be the dose that helped with the symptom reduction and help the person get well and can be tolerated with minimal side effects. So now I want to also go through a few other very common concerns that people who comes to us may have. I think just earlier on, the speakers mentioned as well that side effects is a key concern, and this especially in youth, who may be attending school, or they may be young adults who are working. They certainly don't want to be sort of hampered by the side effects. And so on. And I think the most important thing to say really is that for the antidepressants themselves, usually the side effects are tolerable. Usually they are self-limiting, usually they are transient. And most common side effects, for example, would be things like gastrointestinal disturbances, like nausea, tummy aches, loose stools for a few days. There are, of course, different types of side effects associated with different medications that would be beyond the scope of this talk. But I think one important thing I'd like to highlight is that, this is something that you and your doctor should discuss about. It is certainly something that needs to be kept in mind, and certainly the medication should be personalized to your needs, your preferences, and so on. And that's really important to have a customized sort of treatment plan for you. Others worry about dependence. So some may be thinking, I'm still so young. If I need to start on medications, does that mean that I'll never go off medications? Well, that's not true. I think, like we said before, it really depends on the severity and the recurrence. But we are more understanding it to be like a chronic illness, much like any other physical conditions, Earlier on, I mentioned, for example, that if a person has a chronic illness like cholesterol, they might be sort of thinking that it is probably fine to take cholesterol medicines for a longer term to preserve health. But strangely, this is something that is thought of differently in patients who are suffering from mental health conditions in general, and perhaps OCD specifically. So I think that that's something to think about. And I think another type of, I suppose, the dependent idea may be things like, what if, my classmates or my colleagues see me taking medications, I don't want to be weak and depend on medication. But like what I said earlier on, I think it's really about, thinking of it as an illness and thinking about medications as a way to restore health. And, I think that is a helpful way to think about it. Certainly, I think there have been questions, I think, asked, even prior to this live sort of forum, through the questions that's emailed into us about interactions. And certainly these are also important considerations, just like any other medication that one may take for any health condition or illness. There certainly should be a discussion between your doctor and you about all the medications that you are taking, the health conditions that you may have, and what does all this mean? Is it safe to take the medications? And these are also commonly what doctors would consider first, even before they offer the medication to you. And another issue would be costs. I could imagine, for example, that having to take medications regularly, you'll be concerned about the cost. And certainly if you are school going or you're a young adult working, you're definitely concerned about the cost of consultation and medications. And what I can say about this really is that there are different types of medications. A lot of these medications are subsidized. They are all very often sort of financial support and help available as well if cost becomes a concern. And so these are some things that we should think about, but there are certainly help available, and that should hopefully really not stop us from getting treated. Next slide. So I'll just want to briefly touch on pharmacological treatments or medicines for children and adolescents, to complete a picture. But briefly to say that, for children and adolescents with OCD, usually we only consider medications when the OCD are at least moderate. This is really so that we can give cognitive behavioral therapy a try as first line in the young population. Of course, if the patient or the youth is not keen or not ready for engaging in cognitive behavioral therapy, or if cognitive behavioral therapy is not helpful enough, or there are other reasons for us to consider medications first line, then we should certainly also consider that. And they are relatively, like I mentioned, safe, but we certainly have other considerations that, you and your doctor would be talking about as well. So with that, I come to the end of my talk. Thank you. Back to you, Nadia.
Thank you, Dr. Lau, for the very informative sharing on the medication available for individuals with OCD. So on top of what Dr. Lau shared earlier, an alternative treatment for OCD is a form of psychological treatment known as exposure response prevention therapy, ERP in short. So let us now listen to an audio recording of two individuals on their experience with ERP and how it has impacted them.
I only got to know that it was OCD when I went to see a psychiatrist. But I didn't go for any therapy. I just ate the medicine. 2019, I had quite a bad relapse because I feel that I'm quite a failure. The OCD habits, right, actually got worse. Besides being depressed, I also feel suicidal. That is the point whereby my wife decided that I should seek help. CBT is called cognitive behavioral therapy. The first few sessions was basically my therapist explained to me what OCD is about. Before we start, we identify what are the obsessive thoughts or possible triggers that I may frequently have. Okay, in terms of intensity, the lower intensity ones, that means those that give you less threat, we will grade it in a lower grade, all the way to the challenging ones on top. So I work out a list, and then we started working on the lower intensity ones first. So the whole therapy is basically, I will be assigned tasks to go for the lower intensity triggers and then ERP. ERP means exposure. After that, you do ritual prevention. My lower fears will be things like I'm worried that my switch are not properly switched off. So in order to expose myself, each time when I switch it off, I will just switch it off once without doing the checks or by pressing the switch multiple times. I will just do it one time, and then that is exposure. So you're exposing yourself to the fear and danger that there is a possibility that you can make mistake. As a result of you not switching off the lights properly, you might cause an electric shock or a power failure. So you must stop yourself from doing the compulsive act. You will definitely have a period of time where you have a lot of uncomfortable feeling. So you have to bear it. We call it tahan. That means you tolerate the uncomfortable feeling until eventually to a point that it becomes not so disturbing, not so stressful. That's the whole idea of this therapy, to increase my mental muscle with regards to handling my threats and my fear. So that's why during the first few lessons, we are all targeting the lower intensity ones. And of course, there are certain weeks I have lapses, which I start to have certain OCD fears and threats, which really bothers me. And then if the threats happen to be too high intensity, then we will re-evaluate this threat and just leave it first. So in time to come, right, when these lower intensity ones no longer create any issue to you, we will head on to the higher intensity ones. The beginning is always the hardest because that kind of fear is, triggers a lot of obsessive thoughts. Now I'm tahaning and not doing the compulsion, right? It's like, I have to rely really on the gradual reduction of the intensity of the fear. So all in all, I took about 30 sessions. So currently, my therapist will meet me once every half a year to assess and to review whether is there any problem that I may come across. I already tell myself that anyway, this OCD is not going to be cured overnight. But at least at the moment, right now with the therapy, I have a better understanding of the problem. And it gives me a choice. What kind of level of freedom do I want for myself? Because if the OCD monster is strong, I will definitely be losing a lot of my personal freedom. I will be very much controlled by all these obsessive thoughts. Each time there will be lapses, each time there will be triggers, but each time when I come across the triggers, I would remind myself as far as I can, right, to go through the ERP. Every day if you do this, then gradually when it becomes, I wouldn't say a habit, when it becomes a norm, your muscle endurance goes up. My advice to OCD patients is if you feel like you are in a very serious condition where you feel hopeless, you feel suicidal, you feel depressed, and you don't know what you can do, I will really encourage you to give it a try, because anyway, what have you got to lose? Any improvement really varies from people to people, and even at this moment now when I'm talking to you, I also will have obsessive thoughts coming to my mind. But then, least of all now, I'm able to get by better because I already know, right, how to tackle the OCD monster. So give it a try. Previously, one mistake that I made was I thought I can help myself. But for my case, I can't. Medication is important, but you only reduce the symptoms. Ultimately, the thought pattern, the fear will still be there. So the only way you can be better is if you have to go through two treatments, the medication and also therapy. Through therapy, and if you expose your fears well, you will find that actually you will feel more confident about your day-to-day life. So Give it a try. Don't reject this.
Wow, I must say that the video or like audio experience was very, very insightful on ERP and its effects. I'm pretty sure not many of us will truly know how undergoing such treatment sessions would feel like, and hence this audio experience really gave us a glimpse or an insight into how it goes and its impact on one's life. So now, let's welcome Mr. Desmond Ang, Principal Clinical Psychologist in IMH, who will be sharing more about the treatment options available for individuals with OCD. So his sharing session will touch on cognitive behavioral therapy, CBT, and ERP. Mr. Ang, please.
Thank you. Thank you. Thanks for joining us today on a Saturday and having stayed with us throughout. I think it's really important that when we had Ryan sharing that really CBT is like going through a tunnel. But I guess what I can probably say in our team is that you will not be alone in the tunnel. For most cases, we will try to be with you as much as we can. So that's why it comes to therapy options. There are several that we can look at, which in case that if you do a search, a Google search, you will see that there's cognitive therapy, there's acceptance commitment therapy, there's hypnotherapy, mindfulness, relaxation, and eventually the option that we talk about today is the exposure visual response prevention. ERP. Now, the reason that I think it's important to list all these things down is really because there are many people who ask us, what are our therapy options? Must I always do ERP? Well, the thing is that through our clinic experience, and I say this, I think I would represent, my team of psychologists, my colleagues Hanu, as well as Jackie and myself, we have all been exposed to many therapy treatment. But I think all of us do agree that as of today, exposure response prevention, ERP treatment, which is a form of CBT, still lends us the best result. So that's why for today, we wanted to talk more about ERP, but that's not to say that if you have found the other therapy option useful for you, you shouldn't do it, but more that for those who have not tried ERP treatment before, we would like to share a bit more. Okay, so if we move on to the next slide, to understand about ERP treatment, I think it's critical actually to understand about how OCD works. So in a sense, if you look at this chart, because I think earlier we had a sharing that OCD seems to come in many different shapes and sizes, colors. Like some washes, some check, and some really had concerns about intrusive thoughts, and they seem to be quite different. Now, the thing is that when we understand OCD, they are not that different because they all follow a certain pattern. And what this pattern is really because a lot of times our clients tend to tell us they get triggered by a certain thing. And sometimes this trigger could be quite benign, could be quite neutral. It could be by someone touching, say, the toilet. It could, something coming up from the toilet, or someone could have dropped something onto the floor and they picked it up. And sometimes this seemingly neutral, benign events can become triggers. So I would like to emphasize this because all of us, whether we have or do not have OCD, encounter such things in life. But for our clients with OCD, that really makes them a lot more distressed. In fact, that's why the arrow shows up that when such trigger happens, they do experience a lot of anxiety, a lot of distress. And because of that, and this is where all of us would do when we feel threatened, is that we will try our best to reduce the anxiety. And this is why a lot of our clients say if they see someone touching something they have dropped on the floor, the typical response is that they would want to wash. They will want to check, did that somebody touch me? So that when they do the wash or the check, that brings about relief. So if you go back to what Dr. Danu earlier was sharing, that our clients, when they suffer a lot of this anxiety, when they do the compoundings, it is not meant for pleasure. It is meant for relief because, oh, no, that person didn't touch me. Or that I've actually cleaned it thoroughly. Now I don't feel dirty. Then, however, for this issue about having the relief through the washing compulsion, for example, is that it doesn't last because unfortunately we will still interact with life, we will still go out for classes, we still meet our friends. Somebody is going to touch something again. And so that's why we get triggers, more and more triggers. And typically because of this constant trigger, we end up having more anxiety, and we then do more compulsions. And you notice that this becomes a circular cyclical model where people start to learn that, when I have anxiety, the only thing I can do is to bring down my anxiety through compulsions. And because of this pattern that we know that our clients get trapped, that's why the OCD gets worse and worse over the years. So if we go to the next slide, what we want to introduce, and similarly what Ryan had mentioned in his in his recording, is that in our treatment, we try to help our clients to bring about some exposure. That is, they have to be willing to trigger by themselves, not by anybody else. And when the anxiety is triggered, they have to learn on how to deal and manage the anxiety. And through this, which is why the recording mentioned that he will then learn to grow these mental muscles. In a sense, this is similar to why people go to the gym, is that they learn to carry 5 kg of weight. Eventually, when the muscles get there, they can develop, and then they can say, okay, maybe let me try 6 kg, and then develop, and they get better, and then they say, oh, maybe I can try 7 kg. Step up point by point, and developing the strength and tolerance over time. And if we do this over time, what we tend to get the feedback is that people will learn that they no longer have to rely on compulsions to reduce their anxiety. This is the thing that we say, that you now have the choice of whether to do the compulsions or not. And in which case, because OCD is not pleasurable, most of our patients would choose not to do any compulsions if they can. Okay? So if we move on to the next slide, so landing on just a very simple study, we can just say that if we compare this to other treatment, like in terms of stress management, just looking at this slide, looking at the blue line and the red line, you will see that over the course of treatment, the red line denotes ERP treatment, and that actually over the course of treatment brings about significant symptom relief compared to just stress management treatment. So this is just to show you that actually ERP treatment provides real benefit over just other form of treatment. Okay, let's move on. Thanks. Okay, so again, as I mentioned, ERP treatment really falls under CBT, cognitive behavioral therapy. Generally, for treatment-wise, whether adults or children, we recommend that treatment should be of a certain intensity. So if possible, we are looking at least once per week. And in terms of the, if necessary, if the severity is really high, there is option that we can do therapy on more than once a week. But however, this is of course have to be agreed upon. So usually treatment can happen in the clinic, it can happen in the home environment, and even at the community level, because we know that OCD doesn't just happen in the clinic, it can happen at home, it can happen anywhere you go. However, because I think of COVID situation nowadays, we tend to have to adapt to how we work this treatment in a more appropriate manner. And in terms of the number of sessions, usually we are looking at least 16 sessions to provide any impact. But sometimes if our clients need more, they can go up to 24, 30, 32 sessions. And for those of us who have difficulty coming, say, to the hospital or having any form of face-to-face sessions, ICBT, which is treatment over internet, is an option as well. Now, coming back to it, is that many times treatment will be hierarchical. That means that step-by-step, it's a gradual approach. There is no way that anyone is going to force our clients to do something they're not ready for. And most of the time, treatment is also collaborative, means that we will work with you, we will do with you. It is definitely not underhanded, that we'll never put pressure on you to do something that our clients are not ready to do. Okay. On the last slide over here, I think one of the issues that sometimes people do give feedback when it comes to therapy or even any treatment is that sometimes treatment can sound really tough It can sound really difficult to do. And we found that when we do OCD treatment in the context of life, which is also one of the reasons why we explain to people that actually, if you're studying, you're working, you don't have to stop schooling, you don't have to stop working in order to receive treatment. In fact, we find that people who are still studying, who are still, for those who are serving as, yes, please keep doing so. And treatment is meant to work with schools, work with your NS, work with your colleagues, your superiors on how to make the treatment work for you. Of course, that depends on whether you want to let the schools and so on so forth know about you receiving treatment. So that's why even with treatment, we can see how we can integrate it with healthy living like basketballs, badminton. And one of the quick examples I want to say is that actually basketball is an excellent treatment because it involves getting people who are afraid of contamination to deal with the ball that bounces on the floor. So sometimes it's perfectly to have fun while learning to deal with the OCD. Okay, so with that, I think I'll like to close my section. Thank you very much.
Thank you, Mr. Ang, for sharing more about the alternative treatments available for individuals with OCD, especially in giving us more insight about CBT with exposure and prevention. So we hope that this segment gave you an insight into the possible treatment methods available for individuals living with this condition. Now, another way to help these individuals through their journey is to provide support and guidance for them. I'm sure all of you know the quote, "No man is an island." And with this, the next segment will align with this quote and emphasize on the importance of having a proper support system for these individuals and how it can impact them. So on this topic, I'm sure many of you have also wondered how you can better help and support these individuals who may even be your family, friends, students, or colleagues, or just loved ones. So this next segment will be the ecosystem of support, integrated support and services for OCD, which will focus on the importance of support systems for individuals with this condition. So to start, we've prepared a video on how Geraldine and Claire's family and friends have supported them through their journey and helped them to cope with OCD. So let us now sit back and watch this video that we've prepared.
I'm Terry Mullaney. I'm Claire's mom. I run an OCD support group with 95 people. You know, I had a lot of learning, but I guess I busied myself with that and taking care of Claire that I didn't stop to think that, oh, you know, why is this happening to me? You know, which some people do question.
The OCD became a bit more serious, I think, in my third year of poly. I remember we were having a debrief in the auditorium, and suddenly I just had a panic attack out of nowhere. It was one of the biggest ones that I had, and everybody had to be evacuated out of the auditorium. So, and of course everybody knew that I was the one who caused it. But at that point in time, some of my close friends, like two of my very close friends, they knew about it. And so when that panic attack happened in the auditorium, they were also there thankfully, and so they were there to support me because they kind of knew like what my triggers were, and they knew like what are the early signs, and so they were able to get to me when they kind of realized that okay, like she might be having a panic attack soon, So they're always very supportive, and like they were always there throughout my entire school experience.
It was hard. There were some days where I had to give in to the OCD because we had to get by, until we knew how to treat it. That was my biggest concern, was how is she ever going to live out in the world without me helping her? That was tough. I still get emotional when I talk about it. And she's doing a fine job, and now she's helping me.
I've never really felt treated differently or like isolated because of it, and I think I'm very, very thankful for that, and that everybody was very nice to me. So after that panic attack in the auditorium, people were coming up to ask me, Jolene, how are you? Are you okay? Some of them thought I had an asthma attack, and I was like, oh no, I think it was a panic attack. Yeah, but they're always very nice. I remember there was one girl who also came up to me and said like, oh, I also had panic attacks, and this and this is what helped me and things like that. Yeah, so all along, I've always had a very good support system and like good friends around me to help me through that. So it made things a lot easier than if I didn't have them. Essentially,
it's love, a parent's love. That's all I can say. It was true, pure love. I spread that to the community a bit. We didn't have a support group when we were going through this, and I wanted other people to benefit from one, and that has helped.
My mom is, one of the most amazing people I've ever known. She's my mom, so I'm biased. But, you know, she has shown me this fierce love that sometimes I don't have words for. I'm so overwhelmed by what she was able to do for me and what she sacrificed. I'm going to get emotional now, but, you know, what she sacrificed to make sure that I was going to be okay, right? Like, she always, at every turn, has kept me afloat. I guess I wish for the world that, you know, they could feel the love that she's shown me, which has been really remarkable.
Thank you for this experience and going through this and dealing with this terrible, terrible pain every day. Thank you for teaching me what strength is, you know, and emphasizing love. Well, I never thought I'd thank her for that, but
Well, I must say that the video was really, really heartwarming. It is truly touching to hear about how family and friends can play a role in the recovery or just their journey of living with OCD. It really emphasized the importance of a proper support system for these individuals. So we'll now invite Ms. Yvette Tan, Senior Medical Social Worker and Senior Medical Social Worker and Family Therapist from IMH, to share more about the importance of family support. Ms. Yvette Tan, please.
Thank you. Hi, I'm Yvette. Thank you, Nadia. I'm a medical social worker and family therapist at IMH. Together with Dr. Jackie, she's going to be speaking later. We have been running support groups for caregivers of OCD patients for the last 5 years. So for today's presentation, I'll be using the term loved ones and patients to refer to OCD sufferers, whether or not they're receiving treatment. And I'll also be using family and caregivers interchangeably. So basically, OCD is a bully, right? It bullies patient, it bullies family. Yeah, it's demanding. OCD is, you know, it pesters. It has this constant badgering and undermining of patients' thoughts, their emotion, and their bodily sensation as well. And this causes a lot of distress for patients. And as family members, when we see our loved one in distress, we naturally want to relieve their suffering, right? So if your loved one is just so afraid, you know, of the dirt, you know, on the back and all, you know, we might supply soap, we supply wet ones, we might even help them with the cleaning, yeah. And then when we do that, basically we are participating in rituals, yeah. And if they have a concern about causing harm, right? Like if they hold a sharp object, they might accidentally like stab themselves or, you know, stab someone else, you know, then you might actually help them hide all the sharp objects, you know. Or you might say, yeah, you don't touch, I will do, you know, if anything to do with cutting, I will do it, yeah. And so when we do that, we actually help with avoidance. When your loved one comes home in distress, you know, Mom, just now, did I step on the bird shit or not? And then just now, when someone was talking, you think maybe the saliva entered my eye or not? You know, got enter or not? Got enter or not? You know, distress, right? And Mom may say, oh, son, don't worry, you know, won't happen one, you'll be okay one, right? And when we do that, basically we're giving assurance. We also, family members also do a lot to modify routines, right? If your loved ones is afraid of, you know, hospitals, because, you know, it represent contamination, then we might actually take a big detour. Family often, you know, in OCD family will be late for things because especially if there's a lot of rituals that need to be completed before they can leave the house. So, and then sometimes you end up like, so difficult, don't go out at all, you know, stop that visit. And basically we give out a lot on what we used to love. Sometimes we give up jobs, we give out on our interests and our hobbies, yeah? We give out hanging out with friends. We call all of the above family, not yet lah, previous slide. We call that family accommodation, and family accommodation is just like compulsion. Yeah, it keeps OCD going, and so unknowingly we have been recruited to become OCD slaves. Yeah, we're not really helping our loved ones. We're actually supporting OCD, and then OCD gets stronger. Yeah. Okay. Next slide. Thanks. So it takes about 11 years, we've heard, for a patient to seek help. So initially when OCD first surfaced, family's gonna like put aside everything and just, give it their all, But after 11 years, wow, you get tired already, huh? So a lot of them come in feeling, quite burnt out. And then you also kind of realize that all these things that you try to do, right, to accommodate and so-called help, right, actually not working. So sometimes family will say, I'm not going to help you anymore, And also I learned that family accommodation is not good. And so, but this sudden stopping, and then, it's very distressing, because usually OCD not treated gets worse, right? So distress goes up. So it's not unusual to hear them patient, threatening suicide. You're not gonna help me, 我死给你看, or then, what do you mean you wanna help me anymore, huh? So then they get into rage, and then we see violence. Yeah. And sometimes that is the time where family may bring patient in for treatment. There's also a lot of sadness in OCD, because oftentimes before onset, patients are high functioning in their studies and their work, and family worry about what's going to happen to patient in future, as we've seen in the previous video. So it's a lot of emotional roller coaster. Family feeling helpless and feeling burnout. Life kind of seems to be on hold, and everybody at home is kind of held hostage by OCD, and nobody's happy. Next slide, please. One family dynamic that we often see in OCD family is this opposing like good cop, bad cop thing, ho lang pai lang, and the ho lang always like accommodate the good person. Wow, poor thing lah, and sayang and then you might have another family go like, you spoil him, you keep giving in to him, that's why he never get well, you're just making things worse. And so basically you have two opposing, one parent being mean and one parent being overly kind, and then you have overcompensation actually happening, because the kind one will actually be kinder because your father's so mean, you're supporting, and then of course it makes the father even more negative, perhaps, and more attacking and meaner. The other dynamic is actually you see this happening with the same caregiver, and that is they accommodate. After a while they get fed up, and then they say, I do so much, you still haven't changed, and then you never improve, and then get very angry. And after that, you feel so guilty, and then what they do, they go back to accommodating again. So basically when we allow OCD to split us in this way, or we kind of like ding-donging, it just gets OCD stronger. So next slide. So what can we do really as family? One, educate yourself around what is OCD, what keeps OCD going, and I was recommended the YouTube by Katie Darth, UK. You can take her British accent. She has very nice bite-sized videos explaining what's OCD, about the treatment, and how is ERP, which is a form of CBT, different from your regular CBT, right? And so you get an idea about that. So, find out about that, and read up about it. See a therapist, join a support group. But very important is to see a therapist that actually understand about the complexity of OCD. Because OCD really is a very different kettle of fish. So advice that I would ordinarily give as a family therapist, oftentimes doesn't apply when it comes to OCD. So if I'm working with a family in IMH, I work very closely with the treating psychologist. Just can't understand that, hey, am I on the right track or not? When I'm doing this with the family, correct or not? Because it's really very different ball game lah. So if you have a loved one that is going for treatment, it's very important that you also speak to the treating psychologist, just so that you're kind of alongside them and not going too far ahead, too behind with the ERP treatment. Yeah. Joining a group will help with not feeling like you're not struggling alone. We can then deal with a lot of sense of guilt, feeling resentful because sometimes we feel like giving up, and then feeling very bad about it. So we get that, and a lot of normalizing happening, yeah. But also very important, acceptance. Not yet lah. Previous slide still. Acceptance that you can't change patient, right? Because the responsibility for change has to come from patient, and family can only support. And then the third point is that we want to eventually reduce and stop family accommodation. Research has already found that actually just stopping family accommodation, of course, doesn't stop OCD. But what it does is that it doesn't make OCD worse, right? And when family is managing and functioning healthier, we are really in a better place to support our loved ones when they finally enter treatment. But don't listen to this and go home and say, hey, I learned that family accommodation is bad. I'm not going to do it anymore. No, cold turkey is bad, all right? And we don't want that, yeah? So next slide, this is the right one. Is to work as a team. Not yet lah. Is to work as a team. So, the analogy that you can break one chopstick very easily, but you have a bunch, it's just really harder. So there is a need to work together in a very concerted way so that we're more effective in beating OCD. Finding new ways of relating to OCD. You can hear, that we use a lot of externalizing languages here. OCD is the monster here. The monster is not our loved ones. We don't want the unwanted bully, to come into our life and kind of take over our lives, right? So that's kind of externalizing language. The other thing we like to invite, especially for a lot of caregivers, because we have a lot of love, care, and concern, right? But we need to moderate that. You cannot go like, ayo kasihan, I give in all the time, because OCD requires patient to actually stand up to OCD, yeah, say that I'm not going to listen to you, and sometimes do the exact opposite of what they're afraid of, like they might have to hold a penknife in treatment, right? So these things are very scary, and then we want them to go up against this big bully, So what are we doing then in terms of then standing up to this big bully ourselves? So we need to become bigger and stronger so that we can support our loved one better. Of course, the last point is I would like to invite you to start reclaiming your life from OCD. Slowly going back to doing things that you love, reconnecting, with nature, friends, your interests, so that even if your loved one is not ready for treatment, it doesn't mean that having OCD is going to make the whole family suffer. Yeah, and then what we want to do is basically take baby steps to reduce OCD's influence in our life, and then and slowly we'll get there. So I come to the end of my talk, and good luck to all of you. Thank you.
Thank you, Ms. Yuvatana, for sharing on the importance of caregivers and how they can affect these individuals living with OCD. So her sharing really emphasized the importance of having loved ones around and how it can really impact the entire process and journey of these individuals learning to live with this condition and guiding these individuals in their daily activities. Next, I'll be introducing 3 speakers who will share with us various resources available to support individuals living with OCD. So first off, we have Ms. Hanusia Prithvi Raj, Senior Clinical Psychologist in IMH, to share about the available resources in Singapore. So Ms. Hanusia, please.
Thank you so much, Nadia. I think we've spent the last close to 2.5 hours really learning about OCD, learning what are the treatments available, what kind of medications are suitable, what sort of therapy is suitable. And I think the question that a lot of us would have right now is how do we get access to treatment, and what can we do now, right? And I think the thing about OCD is that, especially if you're a sufferer or if you have a family member with OCD, it's very, very easy and very normal to feel very hopeless about this situation. But I think before I go into the sort of places that we can actually get help, it is really important to remember that OCD is treatable. And as what my colleagues have shared earlier, we can actually reclaim life back from OCD, and you can actually lead life the way you want to. OCD can be beaten, right? So, resources wise, there are a number of places in Singapore for us to seek help. By help, I mean with regards to assessment as well as therapy and medication for OCD. One of the main places that we can actually go would be to any restructured hospital that is near you. So this would be places like NUH, Changi General Hospital, SGH, IMH, or any restructured hospital really. I will be explaining in the coming slides on ways or steps to actually get um, referral to this restructured hospital. Other community partners that we have, in case, if you are feeling, sometimes some patients could have difficulty going to a hospital, as what my colleagues have mentioned earlier, or if you're really afraid of stigma, then there are community partners such as Clarity Singapore, Club Heal, Club to Care, that you can actually get treatment for OCD. Other places, as what Dr. Swapna mentioned very much earlier in the start of the session, would be at CHAT, which is our Community Health Assessment Team. They are located in Orchard and Scape, and especially for teens, you can actually go there to get assessed for any mental health concerns without the worry of having to pay for treatment or worrying about stigma. We also have Reach. Reach is part of IMH, but we work with schools. So what happens is our allied health team actually goes down to the school to actually assess and provide treatment for school-going kids. So this would be school children in primary as well as secondary and JC who have any form of mental health concerns that can actually be treated in the community. So ways to actually access Reach would be to flag it up to the school counselor to actually let them know that you want to get referred to Reach. Apart from that, we also have university psychology clinics, which would be the CHPC, which is the Clinical and Health Psychology Clinic in NUS, and we have the James Cook Psychology Clinic in James Cook University. Apart from that, we also have a lot of private clinics and therapy centers around Singapore, and you can Google them, you can ask around if you do not want to go to a subsidized place, or you can ask around to actually get treatment in private clinics as well. Next slide. Okay, so with regards to IMH, we actually have two main departments that are running therapy and assessment programs for OCD. So the OCD clinic, which is under the Department of Mood and Anxiety, is for adults. It's been running in IMH since 2015. We get referral from all over Singapore as well as overseas actually. The adult OCD team is actually manned by 3 psychiatrists. It has 2 full-time psychologists. You met one of them earlier, Mr. Desmond Ang, and you'll meet the other one, Dr. Jackie, later. We have a case manager as well as a peer support specialist. The OCD team in IMH actually works with adults who have treatment resistance and complex adult OCD cases. They provide individual as well as group treatment. It can be more than once a week. Sessions are relatively longer. It's about 90 minutes. And it can be conducted, be it in the clinic, in the home, or in the community. Because the thing is, OCD is, rarely in one place. It kind of pervades everywhere. So therapy also has to be done in a variety of locations. With regards to the program for children and adolescents, where I work, So we started it in 2014. We provide specialist treatment program for children and adolescents with moderate to severe OCD. So we actually have in our team, we have psychiatrists, we have clinical psychologists, social workers, who are actually working with these children and families with OCD. The main thing about the OCD program for kids is that we do conjoin assessments and treatment with the families, because I think especially for younger population, a lot of times the children are not really aware of their symptoms. They're not really sure on how to actually go about practicing therapy skills. So this is where we actually work very, very closely with the family members to equip family members, especially parents, as co-therapists to fight OCD together. Next. Okay. So with regards to steps to seeking treatment at a restructured hospital, the first step would be to actually go and see a doctor in the polyclinic or GP. And once they have actually kind of assessed you, you can actually ask for a referral to a restructured hospital near you. So it doesn't have to be IMH. It can just be any of the restructured hospital that is closest to you for convenience. And then wait for an appointment. You'll be given an appointment. And your first appointment in these places or even IMH would actually be to see a psychiatrist, who would then do a thorough assessment to see the severity of your OCD symptoms, or if you have any comorbid conditions. I mean, if you have any other conditions apart from OCD, and would then be able to advise you on medication, or if there is a need to be referred to a psychologist for CBT. Next. Yeah. So with regards to websites and books, there are I would say much. There's a lot of information out there. And sometimes there can be quite a bit of misinformation, especially on Google. So I, along with my team, would actually urge whoever is watching this to actually check out websites that are listed here on the site. So this would be the IOCDF, which stands for the International OCD Foundation. So they are based in the US, and they have a lot of very, very good information for be it professionals, caregivers, as well as patients on various topics around OCD. You can also check out www.ocduk.org or the next website, which is the nimh.nih.health/topics/obsessive compulsive disorder. With regards to books, the IOCDF website actually has a lot of books that are that have been sort of vetted through as well to actually provide information to those who need. So again, these are classified and categorized for professionals, for caregivers, for patients, and they also have a list of self-help books if you feel that you're not quite ready to actually start treatment at a treatment facility. So you can actually look through the self-help books to see if you can actually get started on doing some therapy for yourself. Though I would urge, if you are a sufferer of OCD, please seek treatment, because OCD is completely treatable, and it is not as hard as you feel that it could be. Yeah. Thank you.
Thank you, Ms. Hanusia. Her presentation was really very informative in exposing us to the resources available in Singapore. Now, before we move on, we would like to highlight that we are unfortunately currently running slightly behind schedule. However, we do have two very important sharing sessions left on the resources available for individuals with OCD. So we'll also be answering some questions sent in the Q&A segment later on. So if you can, do try to stay till the end to get more information regarding this condition. Now, moving on, let's welcome Ms. Grace Lau, Case Manager for Anxiety Services in IMH, who will share more about her role supporting individuals with OCD in IMH. Ms. Lau, please.
Hi, hello everyone. I'm Grace, the Case Manager of the OCD Clinic in IMH. So as the Case Manager, I serve as the main point of contact between patients and the consultants. I provide psychoeducation to patients as well as supportive counseling to them by checking on them regularly. I also liaise with caregivers to provide, previous slide. Yeah, thank you. I also liaise with caregivers to provide support to them as well. I remind patients of their appointments and ensure that they are compliant to the treatment. I also meet patients in the clinic and sit in with them during their doctor's appointment so as to ensure that I'm updated about the treatment plan. Working as a case manager for OCD patients, I have learned how important it is to instill hope in their recovery journey. As hope is something that is very important, it helps to build their resilience, it reduces their anxiety, and improves their coping skills. So most importantly, hope is a protective factor for patients, and it serves as a push factor to encourage them to not give up. So how can we give patients hope? Simply asking them what we can do to help or support them while being patient and non-judgmental gives them the space to actually be comfortable to share their concerns with us. Even simple gestures like accompanying them to their appointments reassures them that there's always someone there to cheer them on during difficult times. Providing constant reminders that OCD is treatable by sharing success testimonies of how other OCD patients have recovered is essential in providing them with it's essential in motivating them that recovery is possible. Just like an orchestra conductor that brings everyone together in sync and harmony, it is crucial that we too also involve everyone, like the schools, the workplaces, and most importantly, the caregivers, in ensuring a coordinated and holistic case management for patients with OCD. By doing this, we're not just making clinical decisions for the patients, it also allows us to involve other aspects of their lives in which they need support in as well. Hence, if there's any one of you out there that knows someone suffering from OCD, please do reach out to them and encourage them, because your simple gesture and kind words can be the only source of hope that will make a huge difference in their lives. And with that, I thank you.
Thank you, Ms. Lau, for your very informative presentation on the recovery process for these individuals. Lastly, let's welcome Dr. Jackie Yim, Principal Clinical Psychologist in IMH, who is also the President of OCD Network Singapore. She will be sharing about the OCD Network and how you can also be a part of this community. Dr. Yim, please.
Okay. Next slide, please. Yes, next slide. Somewhere, someone is suffering in silence. Somewhere, someone is fighting an invisible battle. Somewhere, someone is wondering, is there anyone out there who understands? It could be your student, it could be your teacher, it could be your neighbor, it could be your friend, it could be your colleague at work. It could even be your mother, your father, your brother, your sister. It could be you. OCD does not discriminate. Nobody is immune to OCD. As you probably all know by now, that it takes about 11 years on average for a person to finally seek help that they need. As a psychologist in OCD, not a day goes by when I'm not reminded of the devastation OCD can bring. I remember a patient telling me that he had absolutely no idea what was happening to him, and he was given the wrong information about his problem. Because of that, it took him and his family many years to finally get the help that was right for him. He looked at me with determination in his eyes and said, there must be a way to make sure that no one else have to go through what he did. So, with the support of a group of passionately dedicated patients, caregivers, mental health professionals, students, and volunteers, We established the OCD network informally in 2018, hoping to create a supportive community for those affected by OCD and other related conditions. We also want to create a network of support that tells people you are not alone. So what is our mission? The mission of our OCD network is to help individuals affected by OCD and other related conditions to live a full and meaningful lives. Our aim is to provide support, information, and resources. We want to empower, educate, and foster a close and a hopeful community for those affected by OCD and other related conditions and for the professionals who treat them. We also aim to support research and training so as to advance an understanding of the causes of OCD and the treatment of it. Supported by Clarity Singapore between 2018 and 2020, we conducted workshops and talks to educate patients and their families as well as the public about OCD and its treatment. We also organized several social activities to help the OCD community to stay together. At the present time, we have an online peer support group, a caregiver support group, and life skill workshops, all to educate the community members so that they can feel more supported and empowered. In July last year, the OCD Network staged the first ever virtual music concert to bring people together. People with OCD and their families and friends and professionals come together to build our community and to remind each other of our common humanity. In 2019, we organized the first ever OCD Carnival in Singapore to celebrate the International OCD Awareness Week. The carnival was a success, with each family bringing a plate of food and professionals joining patients and their families and friends in singing and dancing. In 2019, the OCD Network was honored to be appointed by International OCD Foundation to be one of their global partners, as our work is in line with the mission of IOCDF. This year, we have decided to formally register the network as a society, and the approval for this is still pending. Above it all, we founded the OCD Network because we were deeply moved by the struggles of our clients and that of their families. This movement is for them, for people with loved ones with OCD, and for anyone out there curious to learn more. No matter who you are, your support is necessary to help us to move together to build a close and resilient community. We hope you will join us as members and volunteers and be part of our network and stand in solidarity with the things that unite us all: kindness, understanding, and our common humanity. Thank you for your kind attention.
Thank you, Dr. Yim, for your very insightful sharing. I'm sure we all agree that these sharing sessions were truly very informative and give us an insight into the resources available for individuals living with this condition. We hope that it allowed you to gain more knowledge on ways to better help and support your loved ones with OCD. Now, before we move on to the Q&A segment, we have a short video to conclude the previous sharing sessions that we have had over the past 2 hours. So in this video, Geraldine and Claire will share words of support for everyone here today, especially to individuals living with mental health conditions like OCD. So let us now watch this last video to conclude their stories.
I've always sort of wanted to, do my part in raising awareness about OCD. So, I kind of take to social media because it's a bit easier to speak about it online than, of course, in face-to-face. So I try to do my best and I try to speak up about OCD. The support has really been very nice and people have always, they commented and sort of applauded me, I guess, and saying like, oh, you're so brave and so strong. I mean, I don't think I really am, but it's nice that people are very supportive in general, and they try to share my posts, they comment and things like that. I've never really met anyone with OCD on through social media, but I've had friends who actually because I've spoken up a bit about seeking mental health in Singapore and talking about OCD online. I actually have a few friends who, they will text me and they will actually ask me for advice and ask me, okay, Jolene, I know you sought mental health help before, and I'm wondering how I can do it. So, I'm just glad to be able to spread a bit more, of this information and to help people seek help when they need to. Yeah, and sort of just empower people with that knowledge and the resources that they might need in case they want to seek help for themselves.
When I started working on a longer project in grad school, one of the poets I was drawn to was Emily Dickinson. And she's not someone who people have talked about in relationship to disability in very critical ways, but she is someone who's pathologized for her behavior, right? So I don't know if any of you have read her poems or know anything about her, right? But she spent a lot of her time indoors, right? She rarely left the house. She looked out of this one window in her bedroom and wrote, I would say over 1,000 of these poems. One of the things that interests me about her is, she had this very small life, right? We might describe it as small, right? That she never left home. It's a little bit like quarantine, right? She didn't kind of leave the space she was in. And so some people might see that as really constricted, but her poems reveal this kind of enormous depth and nuance and experience. And so she kind of gave me a lot of hope in terms of thinking about those days when I was young and in my parents' basement, sitting on my hands and knees because I was afraid of doing something to someone, right? Like I couldn't be left home alone. And I was like, I still have a life, right? Like even though this is painful and full of a lot of suffering, right? There's something important that's happening here that I need to attend to and share with other people at some point. So she's been someone who's helped me through a lot of that. She does have a poem where she talks about, it starts off, I dwell in possibility, right? So she describes her home and all the bedrooms in it and the way they kind of open up into the universe, right? So that kind of speaks a little bit to, what I'm interested in, which is having these really small spaces or lives that people think aren't lives worth living and actually having a whole host of experiences that have yet to be fully untapped.
Wow, I think that video was really truly a message of hope for individuals living with OCD. And we hope that it gave you some kind of motivation, encouragement, or at least a reassurance that everything will be okay no matter what you may be going through right now, and reminded you that everything will get better soon. So, with this, we hope that today's session was insightful for everyone here today in helping you to gain more knowledge about this condition and clarify any stereotypes or uncertainties that you had about OCD. So we'll now be moving on to the Q&A segment, where our many distinguished speakers will answer some of the questions that you have sent in. So may we now invite the speakers to come on screen, please. Okay, I think we have everyone on screen, so we'll now take the first question. So the first question is, how do I know that I have OCD? Would you provide any self-reflection tools to determine unknowingly being OCD? Now for this question, maybe Dr. Gupta can help to answer it and share more about how to identify and diagnose this.
Yeah, so I think earlier in my talk, I did mention about these screening tools that, or the screening questionnaire that one can try and use and see whether that, if you notice that you have some of these things, if you have some intrusive thoughts that come into your mind, you spend a lot of time doing certain day-to-day activities that take a lot of time, but you wash your or clean a lot, or you check things a lot, then you may want to get a more detailed assessment. So I think that's probably the uh, best advice that I can provide at this stage. Um, and then, of course, if you think that you do have OCD and it impairs you but doesn't impair you a lot, you could actually look at some self-help books to help yourself if you don't want to see a professional straight away.
Okay, thank you, Dr. Gupta, for your information and telling us about how to identify and diagnose this condition. So our next question will be for Dr. Adrian Low and Ms. Tan Sok Yin. So the next question is, what are the necessary skills to be able to help students with OCD? So Dr. Low or Ms. Tan, please.
Okay, so I think that's a very important question. So I would think this question is assuming that this would be in the context of the classroom. So how can educators help their students? So I think one of the really important thing an educator needs to do is really to strike the balance between being understanding and accommodating at where appropriate, while at the same time not reinforcing the obsessive compulsive behaviors. So as I think was earlier mentioned by Miss Yvette, many times in families there's a difficulty between balancing being too accommodating versus being very overly strict about and and critical. So I think as educators, that similar balance, that tension is really requires a skill and knowing how not to keep on and maybe I give an example. So if a student needs to perhaps keep on checking, and because of that will require additional time. So to what extent do you want to give them additional time to submit versus actually helping them by telling them, I'm so sorry, this is the final deadline, you have to submit them. So that really I think is a skill that, but again, not easy. There's no one size fits all. So this is where probably there needs to be a close coordination with the therapist to find out how much can the educator push encourage the student to be able to challenge and fight back the OCD without causing the person to go into a crisis. I think I hand it time to Miss Tan. I think she can share a lot more from my experience.
Yeah, thanks, Dr. Lu, for sharing that. What I think I want to add on is perhaps the balancing of this part on accommodation, as well as setting forth still the principles of the stringent of perhaps in the schools, the demands, is to be complemented with a nurturing and a caring attitude and transparency. And sometimes I think students are able to take in the principles behind why there is still need to comply to certain standards. However, they need to know the intention of some of this sharing, whether it's really just the need to comply to a system, or it's really having the heart of the students in wanting them to able to really work on their own development. So when this is actually openly discussed, and sometimes the counselors can come in and help a little bit in the communication, I think it will foster a lot more of acceptance, but at the same time, also having a more developmental focus in the whole discussion. And it will help actually maybe to allow the students to take a little bit more responsibility over what do they really want to do in coping, as well as to seek for accommodation and having their own understanding of where they want to come in really resolving these challenges for themselves. Yeah. So I think empathy and openness is really something important in this whole process too. Yeah. Hope that helps.
Okay, thank you, Dr. Low and Ms. Tan, for your very informative explanation. So the third question is for someone who has OCD but refuses to take on psychological exercises like ERP and only wants to take medicine thinking will get well, what can family members do? So even after much encouragement. So for this question, maybe Mr. Ang or Dr. Yim would like to help clarify on how this individual can help their loved one.
Yeah, thanks a lot for the question. I think in the first place, we have to recognize that some of these reasons for refusal of the ERP treatment could be due to a lack of understanding, meaning that there could be certain misunderstanding that they have about treatment that, for example, the psychologist would force them to do certain things that they don't want to do, or that the family would force them. So basically, as long as sometimes there is a miscommunication or misunderstanding, I think the first thing we need to first clarify is to help the person and the family to understand the full nature of the treatment. As we said earlier, there's no way that anyone's going to force anybody to do a treatment that they are not ready to. And I think the second step for me to really consider is that if they have the time to get the information, they understand. Sometimes it is possible that individuals need time to consider. I mean, just because someone has been told about the treatment does not mean the person must agree to do the treatment immediately. So I think it's important for them to consider. And in this case, if they're willing to take medication, that is already sometimes very helpful to give them certain relief, and may even be sufficient to help some of them to get sufficiently well from OCD. However, if all things have been exhausted and maybe even medication hasn't given the most optimal result, and if the client and person does not still want to do the treatment, we may also want to consider other options like even family work. Really, because sometimes if the environment can be discussed with the patient, the individual, and the family, sometimes things can be improved, can be managed, and there are still other options that can be still considered. So in other words, I think all of us in the team will agree that just because someone doesn't want to do, say, ERP treatment, doesn't mean a full stop. I think there is still many things and areas to consider and see how we can further help. Yeah, that's from me.
Okay, adding to what Desmond say, I think like he mentioned previously that ERP is a very cell-driven therapy. That a person must be willing to fully engage into treatment in order to benefit from it. So I think this is a very important point. And another point that I wanted to add is that if for whatever reason, if the patient refused to do ERP treatment, one of the things I think very importantly the family members can do is to actually get to know more about ERP or for OCD and learn some really very helpful ways in terms of responding to their loved one with OCD. I think you have heard my colleague Yvette that mentioned about how you respond really matters. I mean, it does kind of affect the treatment response for the loved ones. Okay.
Okay, thank you, Mr. Ang and Dr. Yim, for the very insightful explanation. So next, the fourth question is hoarding a form of OCD? So perhaps for this question, Dr. Lau can help to answer.
Yeah, thanks, Nadia. And I think this is a very good question. It's a very interesting and perhaps complex question, and I hope to sort of address it as best as I can in a short answer like this. I think the first thing to say is that to me, hoarding sounds like a symptom. It sounds a little bit like how say, for example, someone has pain, and that pain is a symptom of something. It could be a lot of different things. So for some people, they may be collecting a lot of things that they are interested in, and some may misunderstand them as hoarding. So that's one thing to think about. Hoarding can also occur in a lot of different types of mental health conditions. We would think that, for example, we can see that people who are very depressed and unable to look after themselves well may seem as though they are sort of having a lot of things accumulate in their house. People who have, for example, memory problems, may not be able to remember to take out the trash, and it seems as though that things are accumulating in the house and so on. In the sense of OCD, certainly there are some people for whom hoarding is a symptom of OCD. Most of the time, that hoarding behavior is in response to an obsession or fear, that something bad might happen, and therefore they have to have some things that they collect, or they have to retain things in order to avoid that sort of fear from happening, or sometimes they might have to sort of compulsively acquire things in order to do so. And sometimes it could also be related to avoidance.
which means, for example, people who are concerned about contamination might have a lot of difficulty trying to take out the trash, and they may resort to avoidance and having things accumulate like that. Sometimes hoarding occurs on itself as a hoarding disorder, where people have a lot of sentimental value attached to certain things, and they are concerned about them sort of being useful in the future, and therefore have a lot of difficulty throwing them out, which results in a lot of impact on their lives, and we call that a hoarding disorder on itself. That's not exactly and directly related to OCD. But whatever it is, I just wanted to highlight as well that if hoarding is something that you are concerned about, or you are concerned that your loved one may have, it's something that affects their life quite tremendously. Because sometimes we do see that people who hoard, have their the space in their home sort of really cluttered up, and they are unable to walk, unable to have space to do their daily activities, or even worse, they have concerns about fire, you can have concerns about pests. Then it's certainly time to think about seeking help. And if you know someone like that, then maybe it's a time to think about helping them to link up to resources. Thank you.
Okay, thank you, Dr. Lau, for helping to answer this question in such detail. So moving on, the next question is, how can those who do not suffer from OCD better show understanding towards those who do suffer from OCD? So perhaps for this question, it can be directed to Ms. Yvette Tan. Ms. Yvette Tan, please.
I assume this question is like from a peer, and because it's about showing better understanding, I've covered the caregiver part already. And assuming you kind of educated yourself about what OCD is about, then I would say, a lot of compassion, a lot of kindness. Because you've heard, from some of the sufferers, there's a lot of shame and a lot of embarrassment, around some of the kind of OCD they have, Jesus naked, wow, how do you tell people about that, right? And especially when you're a good Catholic girl, So, not being judgmental around that. We're not asking, hoping that people will then tell us what their obsession and compulsion is about. But you kind of, if you know someone already have it, I guess then that is it, non-judgmental. And to treat them such that they are more than their OCD, and not kind of like written off. So that gives hope. So that's what I can think of. Jackie, do you have anything else to add?
No, I think you fully covered everything. I think it's really about understanding, like I mentioned, kindness. I think is compassion. It's really very important, and be very supportive. Just being there for them.
Okay, thank you, Dr. Yim and Ms. Tan, for clarifying on how we can better support our loved ones. So unfortunately, that will be all the questions that we'll be taking today. So can the speakers just say bye to everyone? Thank you.
Bye.
Bye-bye. Bye.
Bye.
Bye-bye. Okay, so thank you once again to all our distinguished speakers for joining us today to help us all gain more knowledge about OCD and clarify all our doubts that we may have. Also, thank you to Temasek Polytechnic for making this forum so successful and providing us with a platform to learn more about OCD and its impacts on one's life. And of course, to everyone here, thank you once again for attending this event, and we hope that you leave this forum today with newly gleaned insights into this debilitating disorder. With this, we have now come to the end of the online forum, so we hope that you can take a few minutes to complete this feedback form that can be accessed via the link in the description box found below. Alternatively, you can also access this feedback form using the QR code that can be seen on screen right now. So with that, that's all from us. So thank you once again for joining us today. Take care, and we hope to see you all at the next forum. Bye!